website. Ms. Dodd, could please record for us? Yeah.
We're being recorded now.
Thank you. As a reminder, members who enter the meeting by phone need to connect their phone to WebEx audio when they join the meeting. If you're not sure how to do it, please use some kind of chat to have IT help you do so. And then please, Ms. Dodka.
All right, so like we do every meeting, this will actually be the last time that I say this spiel. This meeting is being held by WebEx pursuant to the governor's executive orders and mayoral emergency proclamations, which has required the committee to convene remotely until legally authorized to meet in person. And that's actually happening next month. Public comment will be available on each item on this agenda. Each speaker will be allowed 3 minutes to speak. And just per meeting rules, the IWG does not directly respond to live public questions or comments, but of course takes into all the input into account and as part of the official meeting record. I'm now going to take roll call to establish quorum. I believe Member Ison was going to be joining us late, and so is Member Fields. So Member Gonzalez.
Here.
Chair Lassar.
Present.
Member Hammer. Member Hammer.
Here.
Member Lipton.
Here.
Member McGuigan.
Here.
Member Patterson.
Here.
Member Salinas.
Here.
And Member Short. Absent. And Member Wong.
She is getting on. She's having some trouble with her link. So, Ash, would you check the attendee list and see if she has shown up there?
Sure. And in the meantime, we do have 7 members present, so we do have quorum, so we can continue.
Thank you.
And I'm going to just first check that.
I just got a text from Sarah that she's here, but it won't let her unmute herself.
She's
Yeah,
in
she
the
joined.
attendee. She's
Exactly.
in the attendee.
So we are going to need to move her, and because I don't have full host here, there we go. Now I do, and I'm going to make Sarah an attendee. I don't see Member Wong.
Yeah, I'll get offline and troubleshoot with her.
All right. Well, while that happens, we're now going to vote on excused absent members. So hopefully, I mean, we know Member Wong and the other 2 that are currently not with us are going to be joining this meeting. But per the IWG bylaws, the IWG must vote to excuse an absent member from a working group meeting. If the working group does not take such a vote at the meeting or at a previous meeting, then the minutes will note that as unexcused. Any member who misses 3 regular meetings within a 12-month period without the express approval of the working group at or before that missed meeting will be deemed to have resigned from the working group 10 days after that 3rd unapproved absence. So we have no one who submitted excused absences. We just have folks who share that they will be late. Chair Lassard, do we want to hold any discussion before we vote?
I don't think we need to. They've already communicated that they're coming, and even if they didn't, they would communicate that there was some problem or something. They've communicated, basically. So let's just go ahead and move forward. In my mind, that sounds fine.
So, cool. I'll now call roll call and ask each member to vote. I guess because there aren't any excused members, I don't believe we need to vote. So we're going to actually bypass that and move on to meeting rules. I think this is back to you, Chair Lassard.
Thank you. My apologies. So meeting goals. Meeting goals. Today we have, we're going to be updated on Department of Public Health's quarterly activities and implementation report. We're going to increase our understanding of the street crisis response team, skirt team reconfiguration, agree on the direction, hopefully, of the mapping project, agree, hopefully, on the direction of the March retreat, understand the direction of the Office of Coordinated Care and Case Management Expansion Part 2, and be updated on new beds and facilities progress, and identify and vote on a vice chair. We want to remind everyone to please take bio breaks as you need them. We do need quorum, so when you're away from your computer, just put yourself off of camera if you need to, and when you're back, remember to come back on. Next slide. A reminder of what we are here to accomplish. The charge of this work group is to advise on the design, outcomes, and effectiveness of mental health SF to ensure its successful implementation of the ordinance domains. Today we have our intrepid, courageous leaders, Dr. Hillary Crenins from Mental Health SF, Kelly Kirkpatrick to update us on the DPH implementation report, Mary Ellen Carroll of the Department of Emergency Management with support from Heather Weisbrod and Kathleen Silks for the skirt reconfiguration, Dr. Angelica Almeida and Heather Weisbrod for the OCC and case management expansion update, and Dr. David Pading and Yun Jung Kim for new beds and facilities. Next slide. We are now moving on to discussion item 1 related to remote meetings.
Yes. This is our last remote meeting. I know that you are thoroughly disappointed. So just take this in and enjoy this moment of me reading. As authorized by California Government Code Section 54953E and the Mayor's 45th supplement to her February 25th, 2020 emergency proclamation. This meeting will be held remotely without providing a physical location. The state requires that we submit what they refer to as findings every month. These findings are that the IWG as a public body has reviewed the teleconference meeting status in relation to the COVID state of emergency. The formal requirements titled Resolution Making Finding for Teleconference Meetings are posted to the IWG website, and by state requirement, we must record this every 30 days. So, for the last time, there are 2 resolutions. We resolve that the state of California and the city remain in a state of emergency due to the COVID-19 pandemic. At this meeting, the IWG has considered the circumstances of that state of emergency and, as described above, because of this pandemic, conducting meetings of this body and discussion groups in person would present imminent risks to the safety of attendees, and the state of emergency continues to directly impact the ability of members to safely meet in person. Okay. I know. It's a cheerless SAR. Would you like to open it for any comment about this?
Yes, my apologies, I was on mute. Ms. Dodka, please take us to public comment.
All right, so public comment on this item, you're going to call 415-655-0001, access code for today, which is 2490-777-4857, and then you press pound and then pound again, and then dial *3. See if there's anyone in the queue. Currently, no callers in the queue. So I'm going to close public comment. And we are now going to vote that we understand and submit to the state the finding that we'll not meet in person for these just only next 30 days. Do I have a motion to approve the resolution?
So moved. Or, let me
Chair
make a motion to approve the amendment.
Awesome. And then is there a second?
Second.
That was Member Hammer. Awesome. So I'm going to go down and folks will now vote yes or no to approve the remote findings. Member Gonzalez?
Yes, approved.
Member Hammer,
Approved.
Chair Lasar,
Aye. Approved.
Member Lipton,
Yes.
Member McGuigan,
Yes.
Member Patterson,
Aye.
Member Salinas,
Yes.
and Member Short.
Yes.
And has Member Wong made it in yet?
I made it in.
Awesome. Member Wong.
What am I approving?
We are voting just on the last of our remote findings requirement that
Oh.
we are, yeah,
Okay,
meeting
cool. Yeah.
remotely right now.
Yes. Yes. Yes.
Awesome. So we do have 9 yeses.
Ashlyn, Vitka Eisen made it in. Here I
Awesome.
am.
Okay. Member Eisen.
Yes.
Great. So we have 10 yeses. We do have a majority vote to approve these remote findings. I'm going to now move it back over to you, Chair Lasar.
Thank you, Ms. Sadka.
Before we move
Oh,
on,
yes.
can we confirm who seconded?
It was Member Hammer.
Okay, thank you, Member Hammer.
Thank you so much. So we will now move to discussion item number 2, approving the meeting minutes of the January 2023 IWG meeting minutes. These minutes are posted on the IWG website. Are there any changes to the minutes as posted? I'm not seeing any hands yet. Okay. Thank you, everyone. Ms. Sadka, let's go to public comment on the meeting minutes.
So those who would like to provide comment on this item would call 415-655-0001, access code 2490-777-4857, and then you press pound and then pound again and dial *3. And see if there are any callers. Currently no callers in the queue. I am now going to close public comment. We now just lastly have to vote on these January meeting minutes. So do I have a motion to approve the minutes?
So moved.
Member Hammer, and then is there a second?
Second.
Member Lipton. Okay. And I'm going to call roll call and ask people to vote yes or no. Member Eisen.
I don't know if it's customary to abstain if you miss the meeting. I missed the
Yeah.
meeting.
I don't know.
So I
So
either
sorry.
approve or abstain. You can pick.
I think you abstain.
Okay,
Yeah.
got it.
Cool. Abstain. And then Member Gonzalez.
Approve.
And Member Hammer.
Approve.
Chair Lasar.
Approved.
Member Lipton.
Approve.
Member McGuigan.
Approve.
Member Patterson.
Approve.
Member Salinas.
Approve.
I believe Member Short, you were also absent, so would you like to abstain?
I was there during the minutes,
Oh,
so
okay.
approve.
Okay, cool. And Member Wong.
Approved.
All right, we do have 9 yeses to approve the January meeting minutes. I think this is back to you, Chair Lasar.
Thank you so much. We will move into discussion item number 3, Mental Health SF Director's Update with Dr. Hillary Cunnins. And we're very excited to have you back, Dr. Cunnins, and see what you have to share and lead us in today. So welcome.
I'm not seeing that we have Dr. Cunnins on yet. I know we're 5 minutes
okay.
late for this part.
Okay,
If folks want to hold on just a second.
sure. We can take a quick bio break if we need to.
Okay, thank you.
Just let us know. It looks like Dr. Cummins is not yet with us, so let's go ahead and take a 5-minute, do what you need to do break. See you back here at 9:27.
Ash, just for the public, maybe we can move it to the break image so people aren't wondering why it's quiet.
Sounds good.
Morning, Jennifer. Just want to make sure I know you all are running a little ahead, but I'm here.
Thanks, Hillary. They decided to take a couple minute bio break to give you time. Thanks.
Thanks.
Do we have Dr. Cummins now?
We do.
Oh, wonderful. Dr. Cummins, hi, Hillary. Good morning, Dr. Hillary Cummins, as I said, intrepid and courageous leader of taking on a big job, and we really appreciate you. So thank you so much for being here. We look forward to hearing what you have to say, and please take it away.
Sorry, someone was just knocking at my door. Good to see everyone. Good to see you, Chair Lassar. And sorry for being late. I usually bike to work and took the bus, and that put me a little behind, so apologies. I know we have a number of topics that I would ordinarily bring into my director's report. So I know they're upcoming in today's agenda. So I'm giving a few folks a few updates that are sort of a little bit external to the MHSF domains, but thought they were important context information for the group to have. First, I wanted to make sure that the IWG is aware of the formation of a new Board of Supervisor committee or subcommittee on homelessness and behavioral health. This committee has not yet met, and it will be chaired by Supervisor Hillary Ronan with Supervisors Raphael Mandelman and Walton. In addition to this committee being focused on important behavioral health and homelessness issues, all behavioral health contracts will go through this committee as well. We are still waiting additional updates. We also, as this committee requested of us, we are trying to keep you all updated at our monthly meetings on any upcoming hearings involving behavioral health. At the moment, we have been asked to present on March 20th. There is a hearing called on evictions, about evictions and permanent supportive housing. We are there, I believe, to answer questions, and the lead will be our colleagues in HSH. And then there is an additional hearing called on April 13th on the implementation of care courts, and we will be presenting there. I also wanted to share with this group and believe that we sent out a health alert to you all. We sent this out broadly on the substance called xylazine. It is also known as tranq. Xylazine is a veterinary sedative, and it was described recently in a New York Times article as affecting the drug supply on the East Coast, and particularly in Philadelphia. As a result of surveillance testing from our San Francisco Office of the Chief Medical Examiner, we detected xylazine present in a minimum of 6 individuals who had died of overdose. This is the first time that we have, I guess, officially detected this in San Francisco. Importantly to note, all of the positive tests for xylazine were found in the presence of fentanyl, meaning that it is likely, although we don't know for sure, the person experienced a fatal overdose because of the fentanyl. Xylazine has been associated with skin wounds, primarily in folks who might be injecting drugs. And we want to make sure clinicians and anyone treating wounds is aware of that possibility as they see people, as the treatment is somewhat different. We are continuing to work with our colleagues in OCME to surveil the presence of xylazine, to educate community members, and to provide up-to-date information. Shifting topics also on the policy, back to the policy front. Is to give you an update on buprenorphine prescribing and new policy around methadone treatment. So these are both coming out of the federal government. And as I think many of you are likely to know, buprenorphine, also called Suboxone by the brand name, is one of the two most effective medications for the treatment of opioid addiction, along with methadone. One challenge I would describe for folks interested in prescribing buprenorphine for physicians, nurse practitioners, and physician assistants has been the need to obtain what is called a special waiver or X waiver from the DEA. That sort of presented a hurdle as we sought to spread the treatment availability and accessibility. But as of December 29th, with the omnibus bill in the federal government, an X waiver is no longer required to prescribe buprenorphine for the treatment of opioid use disorder. So all that means that all prescribers with a valid DEA registration, that is to prescribe controlled substances, may prescribe buprenorphine. And that is really a huge milestone since buprenorphine was made, was FDA approved and DEA approved for treating opioid addiction in the early 2000s, in 2003. So this is really a huge milestone. Right now, we treat in San Francisco more than 3,000 people per year. This is both, this is using state database numbers. So this includes both DPH treated folks, whether through funded programs or directly, as well as what's happening in the city writ large, whether in other hospitals, clinics, private settings. The next important policy update is that SAMHSA has proposed new rules for opioid treatment programs, that is methadone treatment programs. These rules would essentially make using methadone more flexible. For those of us in this addiction field for many years, we believe that the increased flexibility will encourage more people to be willing to try methadone, which is highly regulated and requires daily or near daily attendance at the outset, with fairly prescribed clinic hours, usually, despite, for example, the work we've been doing in San Francisco to expand those hours. But this is, and part of what drove these changes was during COVID, many of the methadone regulations were relaxed, and there have been a number of scientific papers showing no untoward impacts of those relaxed rules as a result. So this is very exciting. This is a proposal. We have at DPH strongly supported the relaxation of these regulations and have submitted comments supporting them. I want to turn finally to some updates around hiring practices, and we've spoken a lot about hiring and workforce in this group, and I know all of you are as concerned with that as we are, as I am. So I want to share.
Can I just ask, are the slides supposed to be being shown?
I didn't prep slides today.
Okay, fine.
And
Fine, I
I'm
just want to make
sorry,
sure
and
there
I
wasn't-
realize this is like a ton of information.
No problem. I just want to make sure they weren't supposed to be and we weren't seeing it. Okay, thanks.
So two updates I want to share with you. First, at the city level, the Civil Service Commission has approved a proposal spearheaded by Mayor Breed to improve and speed up city hiring process. We expect those procedures will give the Human Resources Department greater administrative authority to determine, for example, how long a test is available, for a particular position, length of time certain jobs will be posted, and create more consistency across the hiring process. The new civil service rules are expected to reduce the city's hiring time by up to 40% for certain positions. But importantly, maintaining principles of the merit system, which of course the civil service system is intended to protect. And currently it takes, just for folks' awareness, an average of 250 days to fill a permanent position. So that is a quite lengthy time and really is an important target to reduce. I also want to now focus within DPH and specifically behavioral health. We are undertaking with our colleagues in DPH HR a really an exciting project to incorporate lived experience into our notice of inquiry used for our hiring. What that means is when we have an open position and we are hiring off a particular civil service list, we send out to that list, are you interested in such and such a position? Please let us know and you will be considered. And we are including lived experience as part of how we then assess candidates' desired qualification for recruitment and hiring. The pilot is a collaboration I mentioned between our HR, behavioral health, and our Behavioral Health Office of Justice, Equity, Diversity, and Inclusion. We're very excited, and the goal is to increase the number of clinicians who are culturally represent clients served and those with the greatest health disparities. This includes Black and African Americans, Latino, Latinx, transgender and non-binary communities. We are also really aiming to prioritize all clinical director and manager level positions, which remain predominantly white and Asian, and we are really intent on aiming to diversify those, the employee demographic characteristics and lived experience in those roles. And the pilot will start, I think, it says February, and I need to confirm that we've actually started, but if not February, but it will run February through August, and we'll then see what impact and outcomes we've seen as a result. So we're very excited, and I just want to thank, there's many, many people who've been working really hard on this at DPH to make this pilot happen. So I'm very excited about that. Let me pause there. This was kind of a broad director's update, knowing that we are now going to turn to a lot of the details that I usually offer in this update.
Dr. Cummins, we have Steve Lipton and Vika Eisen. So member, I don't know who had their hand up first. Do you know which one did?
I think I did.
Okay, please, member Eisen.
Thank you, Dr. Cummins, for your update. I wanted to confirm something. Can you confirm that naloxone still reverses overdoses even in the face of tranq dope? You know, still
Yeah.
that it is still meaningful to give people naloxone. They may not revive apparently as quickly, but they'll keep breathing. I think if that's
Yes, member
important for
Eisen,
everybody to know that.
I totally agree. Thank you for raising that. I'm going to just say it again. You said it exactly correctly. So xylazine or tranq is not an opioid. It causes sedation. It does not stop a person's breathing quite in the way that opioids do. Because it is almost universally to date found in the presence of an opioid, it means that naloxone will work. It will work on the opioid to restore breathing, to reverse the opioid suppression. I'm going to go all medical, the respiratory center of the brain, and the person, and it will work. However, in the presence of tranq or xylazine, the person could still be sedated and seem sluggish because of the effect of the xylazine. That doesn't mean that the naloxone didn't work. And I think this is extremely important to highlight, as Member Eisen just did, because for folks who are used to administering or have had occasion to administer naloxone and see sort of a sudden waking up, which is what happens when only an opioid, or can happen only when an opioid only, like fentanyl, like heroin, like a prescription pain reliever, you might not see that same sudden waking up in the presence of xylazine, but because the person's breathing has been restored, you have preserved, the naloxone has preserved the life.
Thank you. One other follow-up question, which you actually might not have a complete answer for, but if tranq increases the risk of soft tissue infection for injection, people who inject drugs, is smoking therefore, in this case, a harm reduction, like a recommended harm reduction practice?
So I think our sense of the science here is that there's some uncertainty still, that by and large, the wound and skin the wounds have been found in the context of injection. And I think from my own reading and my team's reading, it's not really been seen in smoking or inhalation. However, we are being cautious about right now recommending it strongly as harm reduction to inhale or smoke rather than inject, because there's some uncertainty. I feel, and you, Member Eisen, may know more than we do at this point, but I think it's very much evolving. We, in our health alert, sort of chose to be quiet on that for the moment, not to be falsely reassuring. So I don't know if that's a little hemming and hawing of an answer, because I think there's some uncertainty still.
Yeah, I would agree. And the reason I think there is, however, the reason I brought it up has more to do with outrage around handing out smoking supplies that happens from, the general public, or even the Biden administration, when it is in fact typically, for many reasons, a harm reduction, like a valid harm reduction intervention.
And I share with you that using substances via smoking or inhalation does not, and using clean supplies carries lower risk, obviously, of transmission of HIV and hepatitis C. And so there's other reasons that are extremely important that smoking and other inhalation can offer. So we are not jumping the gun here yet. We're being a little careful, but many other reasons to smoke for disease prevention, risk reduction, rather than inject.
Thank you.
And I think Member Lipton may have froze. Oh, no. I think Member Lipton also had a question, if there's still time.
Good morning. It's not every day you wake up and find the director in the as the headline in the Chronicle. But as you probably know, the lead article this morning was on Kierkegaard and the UCSF study. And I thought it might be appropriate to just tee that up for a moment, because sometimes the closer you're to a story, sometimes the story is not as accurate as it probably should be. So I thought I would tee it up for you to make any comments you might have on the Chronicle story and also the report.
Should I confess that I have not read the story yet, for full disclosure, and I'm sorry about that.
You're quoted in or at least in the
indeed. You know, I think, so I don't know what the story says. Do you, Member Lipton, and if there's a very specific, if there's a specific question, I'm totally happy to answer it, and then I can,
I mean, if you want to reserve that for a later time, that's fine. I just wanted not to let that, not to let it pass. I think the one thing in the article that kind of stood out was a comment from one of the judges who is going to be involved in Kira Court, that in all the time he's been handling cases, he hasn't been able to locate a single bed. And I think that's probably one of the takeaways from this, is that the story essentially is that there is just a lack of resources, services, beds, et cetera. But why don't we, you can, if you want to take the time to look at it later and come back, that's fine, or we can do it at our next meeting.
Happy to come back at our next meeting. I'll just offer two comments. One is, we know that, and this is part of the rationale for mental health SF, which includes in our new beds and facilities domain, as all of you know, building out 400 additional residential care and treatment spots. That was intended and, or is intended to alleviate some of the shortages in some kind of bed types. We know from our treatment on demand report, which we've discussed here, is that the wait times for residential SUD treatment, for example, are by and large very short. And because we are, and we've made some administrative adjustments to even shorten them. So that is an area, for example, where I would describe little to no wait time. On the other hand, we know that there have been longer wait times for people with higher level, maybe higher level and more complex needs. And we, for example, have worked to open additional locked subacute beds. We have worked to open more what we have been calling rehabilitative board and care beds. And we are very committed to working closely with the Judicial Council, who will be implementing Care Court along with us, to adjust as we need. We know that there could be pressures. I'll also add to another pressure point that we anticipate, which is in the intensive case management level of care, where we expect additional folks might be appropriate for. So we share resource concerns and are, we'll work on it, and we have been working on it and expect to be opening, as you all know, additional beds and resources today. And you'll hear a little bit from Kelly Kirkpatrick in the section that follows. But I think those are points that we are all concerned about. I think the other thing that the UCSF piece that was done in combination with UCSF and the California Policy Lab white paper is trying to estimate both eligible folks and then numbers who will come into the Care Court. And we have been collaborating with the state, collaborating with our UCSF colleagues, doing our own estimates of what we expect as we undertake the planning and implementation process. So more to come on Care Courts, and happy to circle back to this next time.
Thank you.
Just due to the time, we have a lot of things, and some of the things that we've been talking about are going to come on the agenda. Steve, I know that you hadn't had a chance, Steve Fields, haven't had a chance, so let's take.
We can't really hear you, Jennifer, unless it's just me.
That's because my headset was up here.
Okay.
Yeah, thank you for that. So we have a lot of things that are coming up. Many of the things that are being discussed are going to happen a little bit later on in the agenda. I do want to make sure that we have one more hand with Steve Fields. So let's take that conversation with, or that comment from Steve Fields, and then we'll move on to the rest of the agenda. Steve?
Thank you. I appreciate that. My technology skills were keeping me out. Anyway, good morning, Dr. Cunnins. I'm interested that you did not mention among the bed issues going on the fact that the residential treatment dual diagnosis programs, a couple of them have closed. uh, to admissions. Progress Foundation, my agency, already has one acute diversion program closed and is struggling to keep another open because of staffing problems. These are programs that have mandated Medicaid ratios, so you can't just titrate down a residential program if you can't fully staff it for a 24-hour period. But I'm curious why you didn't mention that as part of the planning for CBHS. You mentioned board and care, which is maintenance care. You can call it social rehabilitation, board and care, and IMD, skilled nursing, which is institutional, but you didn't mention the tensions going on with Baker Places, program losses, and others. We're losing beds in that sector right now. Thank you. Oop.
You're muted, Dr. Cummins.
Sorry, Member Fields, just was talking without notes, so was not, thinking on my feet. So thank you for raising those important issues as well.
And Jamil, I see your hand, but we do need to move on. Is it a short comment?
Well, I just wanted to ask, what is the plan to bridge the gaps in the African American community, as was stated? That there's a lot of disparities with health, and usually we don't see the results. So I'm just curious, like, if there's any plan to work with organizations or facilities that's in the African American community. What's the plan to bridge the gaps?
So thanks for that comment. The gap, I just want to make sure I'm understanding your comment, your question. So I think you were speaking about hiring and working towards increasing representation among all staff, but particularly clinical and managerial staff, more inclusively of Black African Americans and other groups. Is that what you're referring to?
It's twofold. Yeah, I mean, hiring too as well, but also the health disparities, which was kind of mentioned all in one too. I mean, the hiring is good too, but I did hear health, and I've heard, we hear it all the time. And so I just want to know what's the plan, what's the actual plan to hit that 30% quota in the African American community, whether it's hiring and bridging the gaps of those health margins that we have.
Well, I really appreciate the question, and also I think want to just appreciate also saying how are we going to know where we've come and what our impact is. I think that's what I'm also hearing. So I just want to say, I mentioned hiring as sort of a very specific one part of our larger work around and towards equity, appreciating what you just said, which is it can't just be one thing. And so I mentioned in this context pretty narrowly around hiring practices on our approach to aim to diversify our workforce. We know from lots of scientific studies and people's personal and lived experience that being able to deliver care by folks racially and ethnically concordant staff improves health outcomes for folks who have had experienced worse health outcomes. And so we see that as one element of other strategies, such as our Mental Health Services Act funded culturally competent intervention we're launching in a number of our mental health clinics that aim to deliver culturally concordant care and with behavioral health staff that are racially concordant with clients. And happy, for a future update to come back and talk about both how we're approaching equity broadly in sort of a multiple ways, and also to get feedback on that. I very much appreciate the comment.
Thank you. So why don't we close out on this agenda and move to public comment, Ash?
All right, so those who'd like to provide public comment on this item should call 415-655-0001, access code 2490-777-4857, then pound, and then pound again, and then dial *3. I'm going to see if there are any callers. Currently, there are no callers in the queue. I'm going to wait a few more seconds. Because there are no callers in the queue, I'm going to close public comments.
All right, thank you. So a note to the members is that we have two different, the next two topics. One is the IWG or the DPH implementation report update, and the next one is the street crisis response team. Both of those are very important and are also, we want to make sure that we have Dr. Cunnins here to respond to those. She may need to leave at 11, and so I'm going to keep an eye on the clock so that at the end of this half hour on the implementation report, we can transition and have enough time to go to street crisis response team. So I might poke at you guys a little bit to move on at some points. So let's move on to the implementation report. And Chair Lassar, I'm sorry about the weather and the connectivity problems. We're on the discussion item number 4, the DPH implementation report, and we are welcoming Kelly Kirkpatrick to present on this item.
Great, welcome.
Morning, members of the committee. I'm Kelly Kirkpatrick. I'm here to present DPH's implementation plan, which we provided to the mayor and the board of supervisors earlier this month, and we circulated a copy of the report to you all as well at the beginning of February. The report is the department's submission to the board, kind of summarizing our mental health SF structure, our funding for our mental health SF programs, an outline of the priority population and core metrics. The report we submitted, and hopefully you all have had a chance to look at, reviews milestones and accomplishments for mental health SF from last year, as well as program specific and system-wide goals for mental health SF for the upcoming year. And really what this is just synthesizing all the material presented by program leaders to you all over the past year, as well as our high level goals for the upcoming year. Truly for you all, you know more details, I think, than are probably captured in the summary report, but just wanted to share with you all kind of this synthesizing of the materials that you all give valuable feedback for, and really know in depth and much more detail than probably the report even itself outlines. But this is again for the board and the mayor to have a take from the department on our implementation of mental health SF. So next slide, please. And I know that we have some really great deep dives later today that will actually get into greater detail on all of these subjects that I'm going to touch very high level on. I know that Dr. Almeida is here. Right after my presentation, we're going to discuss SCRT, and then I know that Dr. David Pading is also here towards the end of the agenda to talk about new beds and facilities. So this is just a snapshot for you all, a reminder to you and the board mostly that we launched the Office of Coordinated Care, beginning our care coordination and field-based kind of care management services. Kind of the bridge services that you all are aware of, including our BEST team. We transitioned the Office of Coordinated Care to Epic electronic health records, which will really help us improve data and tracking. and better serve our clients. As you all know, we expanded our case management services. In particular, we added additional funding through Prop C and MHSA funding to increase capacity for intensive case management programs. In addition, in this case management expansion, we launched the mobile outreach teams, which are based at DPH mental health clinics to provide stepped up case management services. So really broadening our case management reach for clients. We, in 2022, launched the 7th SCRT team, as you all know, providing 24/7 coverage and really diverting the vast majority of eligible 911 calls related to behavioral health crises. We also expanded the hours of our Behavioral Health Access Center, the BHAC, to extend into weekday evenings, and we are imminently about to launch our weekend hours, which I'll talk about in the 2023 goals. Next slide, please. As you all know, this is our residential care and treatment dashboard. It makes me so pleased to see so many green boxes on here. We've made a lot of progress since announcing our goal to add an additional 400 residential care and treatment beds. In 2022, we added 160 new residential care and treatment beds. That brings our total expansion to 250 new beds that have opened under MHSF since the end of 2022, and that's nearly 2/3 of the way towards our 400 bed goal. And I'll talk about our plans to get even closer to that in our 2023 roadmap. So next slide, please. So some of our program goals for this year include adding Office of Coordinated Care Management Services dedicated for people with behavioral health care needs transitioning from the justice system. I know we already provide case consultation and support for justice involved individuals from jail health and pretrial diversion projects, but really this will be our intentional launch of planned kind of direct bridge case management, like we're currently providing for people leaving the hospital. And I know that Director Weisbrod spoke to you all about the plans for that work going forward, as well as kind of our systematic follow-up for people discharged after involuntary hold to improve connections to treatment. So you had deep dives on that last month, I know, and then I believe Dr. Almeida is going to speak later today about our continued kind of plan to expand our ICM programs to meet the diverse needs of our MHSF population. And then, of course, we're expanding our street-based follow-up care and linkage in collaboration with the Reconfigured Street Crisis Response Team, which Dr. Cunnins will walk through right after this presentation. So next slide. We are going to be expanding those BHAC hours to the weekend, which will complete the expansion of our operating hours expansion under Mental Health SF. We will be working to implement the vision for the Mental Health Service Center, and Dr. Pading will give you a status update on the plans towards that. Towards our 400 bed goal in 2023, we are planning to launch our 100 residential care and treatment beds. We've already, we're 2 months into the year. We did already expand it by 30 beds. The MINA project has reached its full capacity. And we will be launching our residential step-down bed expansion early this year, in the coming months. This will really get us substantially towards our 400 bed goal. And then we are actively negotiating the potential acquisition and construction of buildings to meet the remaining bed goal, transition contracted beds ideally to city-owned facilities in county, and potentially provide a site for the Mental Health Service Center, which you have heard much more detail about throughout your monthly meetings. Next slide. I think this is again high level for our audiences who don't live in this like you do every month, but we're working, so this is our system-wide goals for 2023, really expanding our capacity to report and evaluate our mental health SF programs. We'll be publishing the core metrics, our first 2 core metrics early this year, as well as we're working on the bed optimization study for the residential system of care to be anticipated in mid-2023. Really focusing on improving connections for our clients to social services, And then finally, kind of working to overcome some of those historical barriers that have led to slower than ideal implementation of MHSF programs. I know we made significant progress last year with hiring over 200 additional behavioral health staff through the hiring push, but we want to do better and continue to do better. We are working closely and really appreciate the dedicated work of the Controller's Office on the MHSF staffing analysis, and really appreciate all of your input into that process, and hope that that will kind of help provide recommendations to help us further overcome some of those hiring barriers for our vital programs. So with that, I am done with my presentation. I'm happy to answer questions. I feel like you all will have one-on-ones with most of these domain leads actually in this meeting. So I'm happy to try and answer questions, and might also kind of defer to later in the presentations in the meeting if there's something specific.
Thank you, Kirkpatrick. We have Steve Fields. Member
Sass, thank you. Thanks for the report, Kelly. I'm curious where the efforts that are currently going on with the Controller's Office, certainly one mandated within MHSF about looking at the salary disparities in CBOs and addressing that issue as a long-term, really structural weakness of our system, that there needs to be a study to base some effort to close that gap on community-based organization salaries with city and county salaries comparably, where that stands, because it's not mentioned in this. And a number of us out in the CBO world are working all the time with the Controller's Office around two of their major efforts in this area. So is that a part of us, to move that forward, part of the system-wide goals for 2023? And then secondly, I'm curious what the reference is to transitioning contracted beds to city-owned facilities. That's the first I've seen that described as an effort. What exactly does that mean? Does that mean instead of contracting with for-profit skilled nursing settings, we would have those beds in city facilities, or does that mean nonprofit providers who have facilities there would be transferring ownership from contracted beds to city-owned facilities? It's an interesting new thing. I haven't heard that phrase before in our discussions.
Yes, to your first question, my last bullet on this slide is about the Controller's Office staffing analysis. Sorry, it's quite small. So that's the one dedicated to mental health SF. I know that the Controller's team working on that is really in the meat of the analytical part right now, kind of crunching numbers based on all the information that CBO providers are providing, as well as drawing down information from central DHR at the city. I also know that there is the broader kind of CBO pay equity issue that the Controller's Office is also providing across city departments. So that is definitely key to our work here. And I'm sorry if I didn't accurately convey that, but it's right there on the slide for you. As for the expansion of facilities in county, we are trying through Prop C to acquire buildings in the city to expand our capacity here for some of those beds that we've expanded under Prop C that we have expanded out of county. So it is the city helping to buy buildings in the city, and we would most likely contract for services either through CBO providers or, through just general RFP, whoever is able to provide those services. So it is in alignment with what we've been doing over the last year and a half under Prop C, trying to build that capacity in county through building acquisition. The city buys the building and then works with providers to kind of provide those services in county. It could include some of our LSAT or PSNF beds. We're just trying to find the right mix of building availability with the funds available to kind of meet those remaining bed goals that we do have.
Thank you. I appreciate I'm sorry that I was seeing the last bullet item on this as being more about the speed with which you were able to hire new civil service. I heard the emphasis was going to be on hiring city and county staff. I didn't hear it connected to the analysis. I appreciate
You're
that
right. It doesn't say
subtlety.
nonprofit there. You're right. I should have been more explicit, but that is
That's
definitely
okay.
key to that analysis.
That's what questions are for. I appreciate it. Thank you.
Exactly.
Thank you for the addition and the question, Member Fields. Are there any other questions for Ms. Kirkpatrick? I'm not seeing any hands. Okay, well, let's go ahead. Thank you so much again. We really appreciate your overview, and I know we're going to dive more deeply, so thank you. So next up, can we flip forward? I think we're on slide, is it 24 now? Yeah, 23. Oh, sorry. It's time for public comment for discussion item number 4. Ms. Dadka, please.
Yeah, so those who'd like to provide comment will call the number 415-655-0001, access code 24907774857. Then you press pound and then pound again, and then you'll dial *3. See if we've got any callers. Currently no callers. Going to wait a little bit longer. Since there are no callers, I'm going to close public comment.
Thank you, Ms. Dadka. We're moving into discussion item number 5, Street Crisis Response Team Reconfiguration. And we are welcoming to join us, I believe, for the first time, Mary Ellen Carroll, and along with support from Dr. Cunnins, Ms. Weisbrod, or Director Weisbrod and Director Silk. So welcome, everyone.
Thanks, Chair Lassar. I think we have just a couple of slides. And I just want to introduce Dr. Mary Ellen Carroll, who I'm guessing some folks don't know. Huge thanks for joining us. We've asked Director Carroll to just kick off the conversation. She'll then hand it to me, and we are happy then to take questions and have conversation.
Thank you, Dr. Cunnins. I am not a doctor of any sort. I think you meant director. During COVID, I got called doctor quite often, so maybe I have an emeritus doctorate award. I don't know. Anyway, thank you so much. It's a pleasure to be here. I'm the director of the Department of Emergency Management. However, I did want to just give you a little bit of background, which is I started my career, so many years ago, in the mental health, working for mental health nonprofits, not to mention about an 8-year stint working directly for ED Shields with Steve Fields at Progress Foundation. I think I started at Conard and went to Progress, and then was at CHP for a little bit. So I have some background in the mental health system. When I went to work for the city 18 years ago, I started at public health. So, but why? So that really doesn't have much to do with why DM is involved in this right now. But I thought it might be helpful for you all to know that I still consider myself and people that work in this field my people. So. But Department of Emergency Management has a division of street response and conditions. Really, this started, I think it's been over 5 years ago, when HSOC moved over to DEM to coordinate. And so the main role that Department of Emergency Management has is coordination and support. And the mayor's office asked us to step in to help coordinate all of these new street response teams that were sort of conceived during COVID and born in the last couple years. And so that includes street crisis, street wellness, SORT, I'm missing one, HSOC. We also have an JFO, and then we also have an RFP out right now for a new community response team. So there's a lot of teams in the field. And so I now have a staff. I have Sam Dodge, who is the person directing all of this. We have a person who is managing HSOC. We have a manager for field, basically what we call our joint field operation, which is only in the Tenderloin right now and south of Market. We have a couple analysts and a manager, and then we also we're just bringing on someone to take over the coordination of ambassadors for the city. So we are here to help support all of these different departments and different operations. But so that's just a little bit of background, but I know we're here today to talk about street crisis response. So the city is consolidating street crisis response team and the street wellness team. And that will be into it. It's going to be basically wellness is going into street crisis, and it will be an expanded street crisis response team. The name will stay the same. We're still going to call it SCIRT. And that is going to respond to a comprehensive array of behavioral health crisis and wellness calls. The new team configuration will include a community paramedic, an EMT, and a peer support member. The street overdose response and POT teams will continue to follow up with individuals that are experiencing overdoses and will coordinate as they do now with SCIRT. These changes will be starting to take place shortly at the beginning of March, and will be fully completed and implemented this summer. So that is the overall, that's where we're going. I do want to just say in general, because I know this question will come up, why? And one of the reasons why is what we really saw between street crisis and street wellness is that we were reaching out to the same people essentially, and our metrics, our outcomes were almost identical as far as who we were able to connect with and who was staying in community, who was being connected with services, et cetera. And then there was one more thing I wanted to say about that. Which I can't remember, so I'm just going to stop there, and I'm sure someone will ask me a question that addressed it. I know Dr. Cunnins is going to talk about the clinical side and how we're going to be continuing to connect and work together.
We have Member Salinas and Member Lipton that have questions. Are you all want questions now, or would you like us to?
Maybe just let me do just a little bit more, and
Great.
Then let's open it up for questions if
Sounds
that's okay. Because I hope that this part will also potentially answer some of the questions. So I just wanted to share with the group sort of, first of all, our close collaboration with Director Carroll and the entire city team as we think about and implement this reconfiguration. We at DPH and in the context of mental health SF will be deploying clinicians in a neighborhood-based fashion along with peer health workers, both seeing this work as part of SCIRT and as part of the Office of Coordinated Care. We are really trying to not think about the redeployment of the clinicians differently or separately from the work that is happening both at large within BHS, within behavioral health, as well as, importantly, mental health SF. So teams, by changing the role of the clinician, teams will be able to offer more protracted and near-term follow-up and care connections for people seen by the street crisis response teams, along with folks with recent hospitalizations and others at high risk of repeated crises. We are expecting this to be able to connect people more effectively to what we're calling acute behavioral health settings. You can see them here: crisis stabilization, withdrawal management. We also are anticipating this could then avert future crisis calls. And I know this group has been appropriately raising issues around prevention pretty consistently, and we hear that. This group will be able to do assessments for psychiatric holds as they have been already, and do referrals for and or transport. We are also anticipating and prioritizing very close coordination with HSH around shelter and housing related needs, and the ability to kind of hold and care coordinate for people in an expanded fashion, as OCC is doing, Office of Coordinated Care is doing, for ongoing behavioral health care, including intensive case management. As Director Carroll already mentioned, DPH Street Medicine and the SORT Poet teams will continue to do follow-up with folks after non-fatal overdose. And also, we want to just acknowledge the importance of working across city departments to create pathways for care for folks who are experiencing homelessness with behavioral health concerns. And I think that's it. I'll pause there and then back to you, Chair Lassar.
Thank you so much. So I think Member Salinas, Member Lipton, and Member Wong.
So I have a couple of questions. So first, to sort out with the on this with the OCC team. So that's the current OCC team that works with SCIRT. This is a bit of a maybe expansion of what they're currently doing. Is that correct? So those are the clinicians that are, we get the follow-up from once our client has been contacted by SCIRT. Typically, they'll follow up with us, usually by email, to let us know. Is that team that you're talking about? With
yes, and we
slide?
are still contemplating specific workflows. We want to really, we do not want to undo things that are working. And thanks for Member Salinas that example. These neighborhood-based clinicians will be using and working with the sort of the former SCIRT OCC team for more complex cases where additional consultation or referrals are needed. So we are seeing this as an expansion and increased ability to do, again, longitudinal engagement as people to sort of get people linked and settled into routine care appropriate to their level of need.
So it might fall particularly for those folks that aren't already linked with, say, with ICM or such, right?
Okay. Exactly.
And they'll be more actually hands-on. So the other question I had is with the street-based team, why is it that the team now does not have a so there's a community paramedic and an EMT and a peer? What is the thinking behind removing the behavioral health clinician from those street teams?
Yeah, so there's a number of considerations. One of them has to do with really the efficacy of and this being such a high value resource on the rig that, you know, the quality of the interaction from the clinical perspective didn't seem to be the best use of a licensed clinician. If you look at the percentage, you know, the crisis teams are out looking for people, running around. There's a pretty big percentage of time that they're just driving around on a rig. Sometimes they find people, sometimes they don't. And for the people that they are connecting with, the challenge of really being able to connect people, the follow-up care was lacking. So there is that. The other thing is that this is going to allow us to have more teams in the field overall because of the staffing. And as we know, a big goal of this is to be able to have, non-law enforcement and these specialized teams to be able to go out to deal with people who are in crisis. So from our perspective, we have to be efficient with the resources that we have, and we feel like this is the best way to move forward. We also have the ability of community paramedics and community paramedic captains to be able to do 5150s when needed. And so that is another thing that the clinicians brought, but that we're able to do without having them on the actual rig. And so those are the main reasons that we decided to make these changes.
Those are my questions.
Thank you.
Thank you. Thank you.
Member Salinas. Member, I think it was Lipton, then McGuigan, Eisen, and Wong. I might be out of order. My apologies.
I'd like to pick up where you just left off. I mean, so as I understand it, you do not have anyone on a rig that can actually write a 5150. So if you've got an individual who is acting out, who is a potential danger to self or to others, or is potentially gravely disabled, how does the team arrange a 5150? I mean, who does it? What's the timetable? And why? And what's the trade-offs that you're trying to achieve here?
So we have throughout the system, within the fire department, rescue captains on board, and this analysis has been done, that they can be immediately available as needed for 5150s. When we also look at the number of holds that are occurring, it's not like they're happening at such a rate that that's the main activity of the clinicians on the rigs. And so for those reasons, weighing all of the objectives that we have here and our desire to get as many interactions that are not just a regular medical call as a backup, those are the reasons. We feel like we can cover 5150s within the system that we have.
So if they do encounter an individual who perhaps at 5150 should be considered, what is the time constraint to get someone on the scene to actually put hands on the patient or eyes on the patient?
It would just be, yeah. So, and I don't have all of the numbers in front of me today, and we're meeting with fire to finalize all of this afternoon. But basically, we have at any given time rescue captains that are available on call throughout the city. So we anticipate that the call would be, within minutes, we would be able to have someone there who can do the hold.
Okay. There's more to discuss that, but I'll let that one go. This is something I think the second question I had, and I think it would be probably better for the department to take some time, look at this, and then respond later. The IWG made a series of recommendations for the SCRT back in May of last year, and I would hope that the department would at least update the IWG as to whether the reconfiguration of the SCRT teams alter any of the recommendations that were made by the IWG last year. And I'm going to ask you to answer that question because you probably don't have the recommendations in front of you. But at some point, it'd be nice to get a feedback from the department, whether they've looked at the recommendations and whether there's any change in terms of how they implemented the SCRT.
When you say the department, which department are you referring to?
DPH.
Thanks, Member Lipton, and I appreciate that, and we will do that. Just to follow up on Director Carroll's comment, just on the 5150s, just to make sure everyone's aware that currently about 5% of SCRT calls involved or resulted in a 5150 to date. So just so it is a relatively small number, which is of course what we want to see is really to minimize. The other, just to answer the trade-off question, Member Lipton, a little bit more, is what this will also mean, we believe, is that additional clinicians are available for more in-depth follow-up than had been available under the prior configuration. So that's an additional potential trade-off.
Yeah, I mean, I agree that it is much better to get more personnel on the ground. It allows you to better serve the intended population. I'm just concerned whether there are trade-offs that are issues here, and particularly if you do have someone who is in crisis, that you can get someone to the site in a rapid fashion in order to put a hold, consider a hold if it's necessary.
I did just want to just in response to that, we are obviously going to be monitoring and evaluating these changes very closely. The fire department has the ability, and we will consider having all of the community paramedics trained in 5150 if we deem that to be necessary. But as Dr. Cunnin stated, we just don't think it's such a low number percentage-wise of the interactions. We believe that this setup is going to work. But again, this is part of, these are new interventions, new operations that we're implementing and evaluating as we go. And it is really our responsibility to ensure that, as we do this, that we are able to pivot and adjust and improve what the original ideas came forward if we see them not being as efficient or as impactful. That's our job in order to shift and pivot to make it so.
Thank you. And I'm sorry, Member Lipton, we're are you wrapped on this? Because we have 5 other people waiting to.
I have 1 second. I have a 1 second question. Do I understand you correctly that there is a consideration that you will train the paramedic and designate them at some point in the future to try to hold if necessary?
Yeah, that's the plan of the fire department. Yes.
Okay, thank you.
Thank you. Member McGuigan. Member McGuigan, are you still wanting to comment? Are you there?
Yeah, he looks like he's working on his mute
Sorry,
button.
I lost the unmute button. I apologize. Sorry.
Thank you. No worries.
I don't know where it went.
No
Anyways,
worries. Just a reminder for others that have spoken to unraise your hand. Thank you.
So I just wanted, Member Lipton had a couple of my questions, so I won't dive into too deep things. Just a couple follow-ups or questions. Can you maybe talk to the group about what exactly is, for your bullet point, what is the assessment for psychiatric holds? Can we touch on that so the group understands what that is? And then that 5%, can you maybe just talk to what that actual number translates to? Because I don't know the total number of interactions. So based on the total number of interactions, how many is that 5%, so we can get a whole number? And then just maybe talk about what the assessment for the psychiatric holds is, what the qualifiers are, et cetera.
Let me invite Kathleen Silk, who directs SCRT for DPH, if I see you on the attendee list, to chime in here.
Hello. Hi, everyone. Thank you for having me. In terms of the 5%, I can give you those numbers really quickly. That's cumulative client engagements with SCRT. So since November of 2020, out of the approximately 15,000 calls they've responded to, we have had 8,814 encounters with people, and 5% of those resulted in a 5150 being initiated on scene. I couldn't tell you what 5% of that number
It's
is.
math.
Yeah.
For last month,
that-
it would have been about 21 to 22 people if you look at your encounters and 5%.
So that shows just off the math of the 8,000, it's about 440 since November. So we're looking at about less than one a day. If you're saying last month was 20 something.
That's
Yeah.
correct.
Okay.
Yeah.
Yeah,
And last month encounters were 437. It usually ranges between 450 to 600 and something encounters per month.
Okay. And then can you just touch base and talk about what is that assessment for psychiatric holds? It just seems to me that personally, in my experience, that we're walking away from far too many of these people that are being encountered.
Yeah, I can say generally that the 5150 assessment is taking place with every SCRT encounter because we are a crisis response team. And so things like collateral history that's available through chart review and Epic and Avatar. Sometimes we also have collateral from having encountered these folks before in the field. Certainly their current presentation and whether they meet criteria for danger to self, danger to others, and grave disability. I also just, as a clinician myself, can say that all of that information and even the law being an objective one, these encounters are really subjective. And so it's a 911 dispatch team that is definitely getting some collateral information, and that's to varying degrees, as I mentioned, but also basing it really, really on these brief 911 dispatch encounters and the information they have in front of them. And so, yeah.
It's more based not on the 911 encounters and the triaging of those, basically more of what gets on scene. So what do you consider, or what is considered for the people out there? What do they consider danger to self or grave disability?
So, I mean, I think without going too far in the weeds, or I think I'm not sure if I'm understanding we're going by the definition of the law 5150 and also what we're seeing in front of us. So there can be a lot of different things that we see.
Yeah. So what is what is the law? Can you explain that? Because I think that not everybody may be privy to that. And then also, how would you explain that to, a citizen that's a business owner and has somebody out in front of their place, or a homeowner, or, school administrators that have people in front of their schools or whatnot. And, the fire department or the street crisis team needs to just walk away and say, sorry, they aren't a danger to themselves, when 99% of the population may disagree with that.
I totally understand, and I will also acknowledge that the law is potentially much more narrow than the public considers. We're talking about imminent danger to self and also the presence of a mental health disorder. Imminent danger to other people in the presence of a mental health disorder, or grave disability, which anecdotally also represents the highest proportion of 5150s initiated by SCRT have been for grave disability. And that is someone who is refusing shelter, unable to clothe, house, or feed themselves based on a mental health disorder. And I will say the vast majority of these encounters with people on the street are not resulting in these holds. The assessment is always taking place, but outside of that involuntary hold, we cannot force people to necessarily accept treatment. We do, when the hold is necessary, we are absolutely placing it. It does depend on the clinical judgment and the presentation of the client and the interaction, which in the case of SCRT, these are brief interactions for the most part. But the law does not necessarily, there could be things that the public consider very disturbing, which they are, very potentially dangerous in other ways, but do not fit the criteria of a 5150 because the law does state that it is imminent danger to self, others, or inability to clothe, feed, or house oneself based on a mental health disorder. I hope that adds clarity.
It does, and I just think that by that definition right there of inability to, clothe, house, and feed themselves, I think that what the street crisis team is responding to is a lot higher than 5% of their interactions. A lot of those interactions would fall into that grave disability category. So that's all. I'm just trying to find out what the parameters are, and I know there's a lot of talk on what we can do preventively, and I think that's a great place to start. But I think we also need to treat the people that we haven't got an early hold on to prevent, that actually are now a grave disability. And I see that we're walking away from a lot of those people that need help and aren't going to help themselves. So that's just.
If I can just jump in briefly, thanks so much, both member, I want to pronounce your last name correctly, member McGuigan, thanks, and Director Selig. So just, I know this is a really important issue that you're raising. I just want to add just a couple more pieces of information. One is, and Kathleen, you may need to correct me, grave disability is actually criteria for conservatorship, but not for a 5150 hold. Just so sort of and Kathleen, am I getting that correct? That the 5150 is sort of imminent. Go ahead.
No, grave disability is yeah, it is covered under the 5150 hold, and then also for if that is a continued or chronic issue, conservatorship, you have that part right, but it is also part of the 5150 picture, and is that, yeah.
Thank you. And again, the people empowered to write 5150 holds, it then under County Behavioral Health Authority, which is awarded to whoever the behavioral health director is, in this case, me. But it then ends up in the individual who's writing the holds determination. So that's just for people's awareness. So when it is dependent on the sort of license is not the right term. So just want to say that ends up being the individual person who's writing the holds judgment. Next question or sort of issue I just want to raise, and then what I hope will be partial solution. I think the tension you're describing is one that all of us are challenged by, who live in the city, who visit the city, who work in the city, either in the in our collective professions or otherwise. And I think we are very much engaged with this, getting this right, and wanting to improve, and ultimately wanting to improve the health of people who are experiencing these challenges. What some of these transitions will afford is knowing that there's this crisis visit. If it does not rise to the level of the hold, the work does not stop, right? This is not intended to be just because in any given instance the hold does not happen. What the reconfiguration will afford us is the ability to continue to work with the find and work with that person to ultimately get them into care, ideally voluntarily. And that is our, of course, all of us feel that we want to coax people into care voluntarily. And when that's not possible, or the person's at imminent risk to do otherwise. The other thing I just want to importantly raise for really all of us, which is when somebody is held and brought somewhere, that does not assure a good, the outcome we all want necessarily. That's really just the beginning of the work. And I just want to make sure everyone, I know we're getting a lot of questions about 5150s, and that is certainly part of what we know will happen and continue to happen. But we I want everyone to be aware is around involuntary care does not necessarily produce good health outcomes without additional connection to both acute care, hospital level care, or lower. So I very much I'm appreciating all the focus on 5150s, and also want to remind all of us that it isn't the answer. It may just be part of it. And we will continue. And I think that this, I wasn't on when this was discussed last time. I know this was part of what was discussed last time, and we're happy to continue the conversation.
Thank you. I have member Eisen and then member Short, and then it looks like others, and member Fields, and then others put their hand back up, it looks like. So I'm not sure that we're going to have time to get to everybody that is re-putting their hand up, but please, member Eisen.
Thank you. So I have unique, I think, perspective on the street crisis response team, because it came to the mental health SF work group. It was already implemented essentially by time we were able to form because of the COVID delays. So this group didn't have a lot of time or opportunities to have input, but the group that did was the Alternatives to Policing group, and I sat on that group as well. There was lots of conversation about mental health the SCIRT team in that group. And that group was very invested in the idea of a multidisciplinary team that included a peer and a clinician and a paramedic. In fact, that model was considered incredibly innovative to the degree that it made national news. Like, we were super proud of it as a city. It then came to this group after the fact, and for us to try to shape it, which it was just a timing issue, so I understand that. So with all that said, I have 7 questions, so you might want to take notes, okay? And one comment. I think it is really, just regarding the 5150 issue, I think it is incredibly difficult to determine a grave disability in a one-time contact with an individual. I mean, grave disability is a complex determination, which is hard to tell given one-time contact. But anyway, 7 questions. Given what I just said about like the national enthusiasm for the SCIRT as prior, the way it was configured, why pull the clinicians off the rig? The second question is, why not? Why do we talk about these things? Well, we need more follow-up. It's mutually exclusive. Why couldn't we not consider a both and? In fact, it might be a really exciting model to rotate clinicians on and off the rig, because sometimes what gets people into care is a continued relationship. So for example, if you see somebody, if the same clinician sees the same person multiple times on the rig, then maybe they had spent a week or 2 off the rig and they do some follow-up care coordination, because this work is inherently relational. But there was not an opportunity to discuss that as an option. The next question is, have you factored in how hard it is to hire master's level clinicians to kind of do street outreach work? And do we think it's really necessary for master's level clinicians to come off the rigs and do street outreach? After all, many of us have experienced highly skilled, non-master's level outreach workers who take great pride in finding and connecting people on the streets to care. Next to last question is, how do we confront the actual lack of services for people? So you can do all the street contacts we want, but if we don't have those follow-up services in the immediate sense, then we're not really going to fix it. And the final question, and maybe you should start with this one first. Why not come to this group, this body, and discuss the challenges before a decision is made? It seems to me that this group is irrelevant, completely irrelevant when it comes to making actual decisions, that the big decisions get made and then brought to the group after the fact. We all on this group spend a tremendous amount of time both on the committee itself and in work groups outside of it. But you know, I'm not sure if we're just here to check a box or be some kind of a rubber stamp. on like how we shape mental health SF. Because when it comes to like where the rubber meets the road, it's an after the fact conversation with us. So you might want to start with that last one and sort of, if you can remember, work your way back up to the first one. Thanks.
Thanks. Thanks, Member Eisen. And I just was taking notes as you went. I didn't get to 7, so I might have missed some. Yeah, I'll just the last question first. I mean, this is just want to acknowledge this is a back and forth we have had with this group really throughout my tenure. I know I wasn't here right at the beginning. You know, this did get pretty far without bringing it to all of you. I just want to offer that we seek to balance the unbelievable depth and longevity of expertise in this group and diversity of expertise in this group with citywide operations and needs that are that go beyond and around multiple city agencies. And I just want to say strongly that we don't experience the group as a box checking group. We are immensely grateful for the many, many hours. We spent a lot of time, I guess I'm just telling you what happens inside the cabinet here, inside the doors, which is talking about recommendations, how we can implement them. When we're unable, we really do aim to provide honest feedback to all of you. So I just want to just start there and really express gratitude and our own and my own and our own respect for you, Member Eisen, for the entire group and the things that you are bringing to us. And maybe this is something that we can really take on, is really in this coming year, talk about timing and how to make the timing of this group and sort of the pace of sometimes what's coming at us align better with this group so we can do a better job. And I know you have an upcoming retreat and really thinking, in that, maybe really thinking, helping us be really concrete about ways we can improve in this regard. You made 2 other, let me just address the master's level clinician comment for a moment and just share with you sort of how we're thinking about this. We agree that you don't, and in fact, for outreach purposes and engagement purposes, I concur wholeheartedly that just a master's does not confer necessarily greater ability to do some of have the skills or work that we see as vital. I think where a master's level clinician or an experienced clinician can be helpful is using having high level of skill in sort of evidence-based strategies and interventions. And that's where we're really hoping to increase our ability to implement. So not using master's level clinicians for finding people necessarily, but for delivering interventions, for example, critical time interventions, which is a model that's been used elsewhere in New York that helps move people, for example, again, into housing. You also raised the important issue of not having resources always to sort of have follow-up of clients. And I think in some cases that is true. And I want to just say in some cases we do have the resources I mentioned earlier, the substance use disorder treatment, where we do have capacity as Member Fields rightly reminded me to raise, is in some other areas, including dual diagnosis residential, we may not. So just want to acknowledge we are continuing to work on that including and I perhaps should have mentioned this up front, we had a recently released RFP, which we will send out the link to this group if it hasn't gone, for expanding intensive case management. I think just memorize, and thank you for mentioning the rotating clinicians on and off the rigs. That let me, I am open. We can bring this back to our team to, with our partners, DM and Fire and my own team, and happy to talk about that as well as other ideas. And so if I can defer the answer to that, but it's an interesting idea. Thank you.
Appreciate it.
What did I leave out?
Yeah, it's okay. I just want to note that we meet monthly. This group, it's not a quarterly meeting, so it is. I would ideally we would use this group. The department would use this group to say, this may not be working. We're thinking of a new idea. What are some of your ideas? And that's the point of meeting monthly. And in my mind, that's the best use of this group, is to say, we're having problems. We're thinking, what do you think? What are your ideas? Because I think that's how we would like to be engaged. And that's where I think we could hopefully bring value. Thanks.
Thank you, Member Eisen. Thank you, Dr. Cunnins. I believe it's Member Short's turn. Member Short? Oh, no, the hand went down.
I'm here, sorry. I was rehearsing. No, and I only have 10 questions. Just kidding. So I feel pretty frustrated right now. The SCIRT team was created as a mental health crisis response team, and it was created that way because the mental health SF legislation directed that, and also because it seemed to be a reflection of what the public wanted. I do not have confidence that you can have a mental health crisis response team without mental health professionals on the teams. I find this really problematic. And I think if people had the misunderstanding that the core roles of the mental health professionals, clinicians on the rigs were to do 5150s, well, that's just wrong. And there's far more that they can do and did do and should be doing, and that we need them for. As a matter of fact, 5150s are really seen as a last resort. They should be helping to build trust with clients, which they did. They should be getting people into services and resources, and obviously doing the clinical work, including diagnosis, maybe relating to a 5150, which I am still very skeptical about others without the credentials making those calls. At any rate, so I am sitting here honestly thinking, I don't believe this falls under the purview of mental health SF if it's not a mental health crisis response team. I'm also concerned that that's how we've branded it, to the public. This is what people expect. The makeup of the team, as described now, it will not provide a proper and appropriate mental health response to folks that are in crisis on the streets. They just don't have the tools, resources, and training. To worry about this emphasis on again, the 5150s as if, well, we still are going to solve that problem and have people being able to do that. No, that's just off track. That was never the core role of this team. So I also know that it was, funded through Prop C funding, and as a mental health crisis response team, a multidisciplinary team, as Vika described, And that again was another core component of sort of why they, those folks on that board, Prop C, approved funding. So I feel like there's a bit of a possible bait and switch going on, honestly. And I think that that's okay to try to make these changes and decisions, et cetera. But again, as Vitka raised, not without a really robust process of working with the community, asking the experts, particularly the people who've been on these teams. What are these mental health clinicians saying is the reason? Back to that, the reason, I haven't heard anything that really is compelling about what the problem was that this is trying to solve and why. I did hear what folks said about why this came about, but it's not really making a lot of sense to me. I feel like instead what's happening is that this team is just being completely like converted for another purpose, which again is fine if that's what the city may decide to do, but does not belong under mental health SF then, and should not be promoted as that. And then again, I just want to go back to I actually feel pretty disrespected, and partly that's because this is not the first time. We've had this conversation before about bringing things to us after the decisions have been made. It does not feel like we have a role here to play, and certainly not that our expertise or experience or opinions are being listened to, respected, that we're part of this process. And I'm going to be honest with you that I've had conversations with a few members about whether we want to stay on this body, because again, not just this, but I think this is a big example. Like, I don't want it to be lost what a huge change this is that's not being proposed, that's happened. And guess what? I read about it in the Chronicle. That's not where we should be finding out these things. So even from that standpoint of like informational, even if you're gonna disregard us and make decisions, boy, please let us know what's up. It's embarrassing, right? I'm also, I do have the 10 questions, obviously, but I'm curious about what's going on with the jobs. There are a bunch of clinicians employed, to do this. Where are they going? What were they told? And then I want to say that at least one of the sort of reasons for this that I heard, if the issue was really about, and I totally understand this, like we were doing all this work on the rigs and then there wasn't enough going on at the other end, with follow-up, we weren't able to do the intensive case management we needed there with people. Okay, that's a call for more resources needed. That's not a call for diverting resources. Or at least I on this board, but I really think my colleagues as well would be the first to try and help with that problem and work on leveraging more resources for that. I honestly don't think this should be the end of this discussion. Obviously, a lot of us have a lot more to say and a lot more questions, and I would like, I don't think I'm gonna get this, but my ask would be to really halt this grand dramatic change until we, not just us, but I don't know, I don't have confidence that a whole lot of other bodies and stakeholders have been consulted or brought into this discussion either. And also particularly that we understand what problem this was meant to solve, and we all put our heads together to figure out what the best way to do that really is. If nothing else, I would like a manner of venue for us all to get together with some of those other stakeholders, as I mentioned, and really, work on this and see what we can do to get this at least more on the right track, even if we can't reverse history. Thank you.
So I'm going to start to respond to this. And I'm, I'm not part of this group. This is the first time I've ever met any of you. So I have the advantage of, I think plausible deniability, at least that is now over, but that's for now. And I'm certainly open to, if anyone knows me, certainly open to collaboration and input and all of that. But here's what I want to say overall. As you all well know, you wouldn't be here if you didn't care about it, and we're well aware. We have a major crisis on the streets. We were given a mandate to stop police response to behavioral health crises, which we have largely done. We certainly, in operational context and through 911 dispatch, which is also under my department, we have done an enormous amount of work to support. Even though I don't know all of you and I wasn't part of this, I can tell you that my organization and myself have dedicated the last 2 years in ensuring that we can implement these initiatives. And I'm very proud of the work that DEM has done, and particularly on the what we call the DEC or the 911 side, to change our protocols, to retrain over and over again our dispatchers every time that there is a change, so that we can support this these initiatives. And as an example, I'll just give you, they're down to a minutia about what is agitated versus violence, what is a weapon, how do you tease that out, and how can we maximize the response, maximize the non-law enforcement response, even on the margins. That's what we have been doing.
Dr. Carol, can I interrupt you for a second,
yes.
please?
Yes.
Thank you. I think you just really shut a bunch of people down. I just want you to know that, myself included. That was very insulting, what you just did.
I don't understand. In what way?
I'm aware you don't understand. That's what I'm trying to tell you. So I need you to just pause for a second. And you talked about plausible deniability. And you're talking to this group like we don't know and don't care and haven't given many, many years and have much expertise. What you just did was very insulting. And so I need you to just back up. Nobody can hear you in how you're just trying to be defensive. That was not appropriate. So I'm letting you know that was not appropriate. So I'd like to reset. I don't think you meant to insult us, but I'd like to just reset with you and let you know that that was not cool. And so I'm just inviting us all to take a breath, myself included. And we're going to have to come back to this conversation at our retreat. And I appreciate that you want to explain how you've prepared your folks. And believe me, you should and you need to, and that is your job. What we're talking about is something very, very, very different. So we're not asking you to prove that you're good enough right now. We're asking to be part of the decision-making process. And we've spent, this is the third year of many of us doing this work. And so what I think what we need is a different conversation. So I just want to press pause on this and on your explanation, because none of us are going to really be able to hear it. And I appreciate and want you to be able to work with this group in a beautiful and good way. But first, I just want you to understand that folks need to be approached differently than how you just did. So we've spent a lot of time building a relationship with Dr. Cunnins, and we feel that, or many of us feel that she's trying to answer the questions. And so, of course, we know about all of the overdoses. Of course, we know about all of this work. We've been doing this work, many of us, and our lives are on the line and our communities on the line every day. And so I just want to press pause so that we can invite you to come back and answer the questions a little bit differently. Excuse me, sorry, I got a little bit stressed about that. But what I wanted to say is that the members here are frustrated and not feeling heard. And so we need to pause with that part before we move into how you're prepared. So Jen, I'm going to actually go into maybe the next couple questions so that we can get back that I don't think we need to hear the preparation for this right now. I think we need to be heard on our questions. So then we can come back at our retreat and actually be able to get into formulating how we answer them. So I'm not trying to be disrespectful to you, Director Carroll. I appreciate all of your work and all of your experience. So I want you to know that. I want you to be sensitive to the concerns that this group is having. And so I want to invite Member Fields and Member Salinas to ask their questions, and then we can then get those logged in, and we can come back and invite you back for the retreat to have a deeper dive. I think, unless others want to hear more from Dr. Carroll on where she was going. So you all guide me on this, please. Member Salinas, did you want to, or Member Fields?
I was just going to jump in with I was going to do a very short clarification. It's been a powerful discussion, and you can, when you hear the report out from the retreat folks, I think the themes that have been raised here are just profoundly at the base of the relationship between the community, the experience in the community, all the way from people with lived experience to family members to people who've been working years in the field. And I think what we've seen from this, and I think the room for us to make some steps and change this, is that the skirt process started without a lot of the leadership present now in the Department of Public Health and other areas. And I think if we had been constituted, we might have gotten off on a better foot. But just the fact that it so quickly needed adjustment, none of us were surprised. And if we look at that report that a lot of people put time into from the IWG, critiquing and asking questions, and if that report were taken seriously, we wouldn't be in discussion. We'd be reconstructing a way in which DPH, the other departments, work with this group to get the best solutions. And there needs to be some humility on both sides about where the expertise is. And, you know, I've looked at standing up emergency intervention teams my whole career, and there are embedded problems with it that never got discussed, that could have been incorporated into a more comprehensive discussion of even the original skirt model. That never happened, and this is what it results in. I think, you know, that we're going to move toward a different collaboration. And I just wanted to say, well, I was going to say just one very short thing, which is one of the frustrating things. I can hardly wait till we meet in person. And, you know, going back to about an hour and a half ago, and, you know, the answers even around the 5150, I think, weren't complete. But the 5150 isn't the issue. We should follow up on what happens. That's just a hold for evaluation. It is not a hospitalization. It is not an agreement that the person fits any of those criteria except in the moment. When we're looking at outcomes and data, the outcomes we should hear about that 5% was how many were actually considered needing hospitalization on a 5150 criteria, a 72-hour hold. How many did the emergency room kick right back out to the community within 5-10 hours of having been brought in? That's the sign of whether this intervention is a successful one or not. And we need those kinds of numbers, because that tells us we're looking at the effect of the things we do, not just the things we do. And we don't have that number. I don't know what the number is around that. And that's what we need to start looking at. And I know the retreat group is trying to look at that. We want to help the departments understand that ecology of what happens when mental health and any intervene in the lives of somebody. Sometimes they wish we'd go away, and they're better off if we do. We got to take an understanding of what's the outcome of this. So that's where the 5150 issue becomes very complicated. And so, and we need to be able to share that with everybody who may not work in that area of the world that thinks a 5150 means anything but a conveyance to an evaluation, which depending on how crowded the emergency room is, whether there are any beds available, those decisions subjectively determine whether someone is right back out on the street after 6 or 8 or 15 hours because there's nowhere to send them. That's what we're trying to correct with mental health SF. And everything we do is a gateway into that discussion. And I think we're gonna all be stronger in this if we start working together on these solutions and do better. So thank you. That's what I wanted to say.
Thank you, Member Field, so much. Member Salinas and then Member Hammer.
I'm sorry, I put my hand back up just because I do have one concern with the current plan for 5115 folks then that the team determines. Just that because I do very much appreciate that we now have an option for non-police 5150s, all the clinicians do at Citywide. However, when we are conducting a 5150 in the community, unless we have a concurrent medical condition, we're waiting a very long time for fire department to show up. And so I know that it's stated that fire department will be there within minutes. I'm wondering, why is that not the situation when we are doing 5150s in the community? Because we'll wait a very, very long time. We were waiting a very long time also for police. So it hasn't gotten any better with fire department. It's just at least the transport is more is less stigmatizing, more humane. This is a question I think I would like for Director Carroll also to address, like how can this be improved then the response times by fire department for all 5150s. They had another, and then I think just piggybacking off of what lots of folks have said, or what Steve Fields just said, is that what constituted a 5150, what was determined, clinical presentation for which someone could be put on a 72-hour hold, a 5150 hold, and then a 5250 hold has changed over time dramatically. And I think it is in direct relation to reduced number of inpatient beds. And, we used to have 2 PSs, right? PS North and the PS at the General, right? An inpatient unit there at what is now Mount Zion. We used to have double the hospital beds at the General. We used to have, unit at St. Luke's. And so now a lot of folks that are gravely disabled, people who cannot food and clothe or shelter themselves, are absolutely not 5150able, right? I think what constitutes grave disability these days is merely that, you are so ill that you can't even feed yourself. So literally you will die from your grave disability, right? And that's changed, dramatically over time. And so I think that we have to look at, I know everyone has brought up, Steve McQuiggan brought up that, all these folks that are on the street, and yes, they are getting turned away, right away. When we are looking at, as behavioral health clinicians, who actually we can 5150 on a grave disability is drastically different than it was 10 and 15 years ago.
Thank you, Member Salinas. I'm gonna also get Member Hammer's question and Member Lipton, and that'll be the last one. And I think what I'll ask is that if we could please have the director come back to our retreat and kind of press refresh on that. Is that okay? Member Salinas, I know you expressed a question. Is that okay to wait until then, or? Yeah, okay, thank you. Member Hammer?
Thanks, Chair Lassar. I was just going to weigh in and before you made that last comment. I just worry that we're pushing too much off to the retreat when it seemed like we were really going to focus on sort of process questions and really getting to the bottom of this recurrent frustration that we've had about how we, IWG, work with the city departments and get better in sync with program development and how decisions are made about mental health SF programs, so that we avoid some of the issues that have been, I think, really eloquently raised today. So my worry is by deferring really the detailed questions that we have and Director Carroll's responses to the retreat, that it'll take up so much of the retreat. And I'm just wondering whether there's any way of adjusting the agenda today so that we can actually talk more about the questions that members of the IWG raised for Director Carroll.
Okay, great. Thank you for weighing in. Let me ask Ms. James and team, Member Ms. Kirby, if they can text me, let me know what they want to do. I'll just take Steve Lipton right now, and then we can come back and figure out if we can just roll with this. That would be great too.
And Monique, we can roll with this. I think that after Steve's comment, maybe let's take a break. We haven't taken a break yet. And then it'll give us a little time to kind of reconfigure in that break.
I need to jump in for a second, Chair, if you would. I was asked to come to this meeting for 20 minutes. I have canceled 3 meetings in order to stay here. You completely shut me down, which is fine. You gave me some feedback, which I hear. If you, as a director for this department, as a person who is supporting a multidisciplinary group of people who are out on the street every day, working so hard, trying to do their best, and that's everybody across the board, from fire to the DPH team to DEM to the contractors. I think whatever format you would like me to come back with, it should be pretty clear. My time is also, as yours is, very valuable. And you should have other partners that are critical to this team. We also are under attack. Basically, we have 2 lawsuits that we're dealing with right now. So if I'm coming off a little bit like trying to and I don't know any of you, with the exception of Steve and a couple people. So I was trying to share a little bit about what I have been doing as part of this. So now we know each other a little bit. This was, I certainly apologize if I insulted anyone or shut anyone down, but I certainly feel completely shut down and not very valuable, giving you practically half my day here. So happy to come back when we have a format that makes a little more sense. Like I don't even know anything about this group. So so that's basically what I want to say.
And thank you, Director Carroll. Are you needing to go now, or do you want to stay and answer some more questions now, or do you need to go?
I mean, at this point, what I would request is that the questions you have, that you get the questions together, and then we'll come back with all the people that can answer those questions, and we'd be happy to do that. And whatever time you need, let us know, and we can schedule that time.
Thanks. Sounds fair. Thank you so much.
Thank you.
I lost who was next. I think it was Member Lipton and Member Hammer. Thank you. So I think, Jen, you're mentioning that we need to do a break really quick. Is that what you want to do?
Why don't we take a break? Let's all step away, take a break, be back around, 11:30
make a quick comment, or do you want to take a break, or do you want me to make a quick comment?
Yeah, make your comment.
I'm not going to ask a question.
Yeah.
I think Member McGuigan raised a really good question about the concept of the hold. I don't think what was explained to this committee today is accurate. in terms of what a 5150 is. And and I think there are words being thrown around between 5150 and assessment, and they're different concepts. And I'm really concerned that we're not getting, a straight answer, because a 5150 itself is a custodial hold to get an assessment. And the assessment doesn't have to be done in the field. It's normally done at a designated facility. And any member of a crisis team can be designated by the county to write a hold in order to facilitate this. And comment was made today about imminent danger or imminent harm. That is not a sole criterion for a hold, and expressly stated in the statute that the individual making the determination of 5150 is not limited to consideration of the danger of imminent harm. So I'm really concerned that we need to have maybe even a little education on this subject. And I'm just kind of dismayed that in terms of the direction, in terms of which is gone. So with that, we can take a break, and maybe we should discuss this at the retreat as well.
Thank you. Thank you so much. So let's take, it's 11:27. Let's come back at 11:40. Give us a little time. I'll see you then. Thank you. Ms. Sadka, if you could put the slide on break, please. Or Ms. James. Thank you. And find it. So thanks everyone. I hope everyone got to take a breath. And again, I apologize for if any way I was insulting to the director. That wasn't my my impulse or my desire to insult her. It was just to press stop and make sure that this committee feels the level of respect and care and consideration and hearing that it deserves, and that you all deserve, that we deserve, for our work, for our expertise, for our knowledge, for our care, for our hours of service. So thank you all so much for that. And I think Ms. James and I were just speaking. I also talked to Director Cunnins on the break. And so with Ms. James, I think where we landed is that we're going to go ahead and mark all the questions, articulate everything, all these pieces that we have. And so to Member Hammer's point, really wanting to get the responses, to not push them off, to not wait, but to get a really comprehensive understanding of the big picture. So Ms. James, maybe we can go back to where we were. Oh, and Dr. Cunnins has left for a while. She has a meeting. She'll be back at noon, she said. So if we have more questions for her or want to connect with her, that would be the time. Ms. James, I'm not sure where we are exactly. If you could get us somewhere.
Yeah, so why don't we go back up? Because these things are the conversations that we just had. Some of these are all linked and connected. And so we want to be sure that we talk about the mapping and the retreat. Those two things are part of this process and understanding. I think, though, before we go on to those things, we do need to do a public comment about all the, that last section before we kind of transition over.
Very smart. Thank you.
Yeah. So, Ash, could you please lead us there?
Sure thing. So those who'd like to call in for public comment on this item would call 415-655-0001, access code 2490-777-4857, then press pound and then pound again, and dial *3. I'm going to see if we have any callers in the queue. Currently no callers, but we do have a lot of folks who've joined us from the public, so that's awesome. I do now see someone has gotten in the queue, so I'm going to unmute you and then you may begin your comment. It looks like we have tried to unmute you, but it is not unmuting.
Oh, 45 attendees. Thanks everyone for joining us. Can we get the, please do, since we do have the public joining us, we definitely want to hear from you.
Public comment this way?
Yeah, there you go.
Oh, okay, great. Thank you. Can I start now?
Yep.
Thank you. My name is Fatima Veyan. I use she, her pronouns. I'm a reentry social worker at the Public Defender's Office. I was born and raised in the city, and I'm a bilingual and bicultural licensed clinical social worker. And I submit public comment in support of keeping mental health clinicians on skirt. They have better knowledge, skills, and training than paramedics to respond to behavioral health crisis and evaluate individuals for psychiatric holds. Clinicians are also more likely to build rapport, trust, and consensually support folks who aren't in need of psychiatric holds. It's concerning that key stakeholders were not consulted before removing mental health clinicians from our mental health crisis response team. I fear that SCIRT is shifting its focus towards numbers outcomes, emergency medicine, and rash approaches to crisis response. I also fear that without clinicians, SCIRT will start to unnecessarily place community members into psychiatric holds, which would then cause more harm and trauma that SCIRT was initially intended to prevent. So I urge this working group to keep clinicians on skirt rigs. In my professional opinion, removing clinicians from skirt would be unethical, a disservice, and contrary to the wishes of non-police key stakeholders. Instead, the city should solicit feedback from community members who access skirt services on how to improve service delivery. Skirt staff should also receive comprehensive, ongoing trainings that is comparable to those received by model non-police crisis response teams in the US. Thank you.
Thank you so much, Fatima. Any comment from you, Chair Lassar? I know we can't respond, but
No,
directly.
just very glad to hear from you, and we appreciate your presence and your words.
All right, I don't see any other callers in the queue. We're going to wait a few more seconds.
Ms. Tucker, can you please give instructions about how to raise your hand, perhaps? In
Yeah.
case people do want to.
So again, to raise your hand, you call the number 415-655-0001. You enter the access code 2490777-4857. Then you'll press pound and then pound again, and then you'll dial *3 to line up to speak. I don't see any other callers in the queue. So I think I'm going to go ahead and close public comment.
Thank you, Ms. Tadka. So just checking if there's any other hands from the IWG working group before we go into this next mapping discussion. Are we good to move forward? I don't want to just make a decision for everyone.
I don't know. I see a whole bunch of people too, and I'm concerned that there are people that want to comment and not sure what the issue would be or how to, but I am worried about that. So maybe if nothing else, if we try again, give another opportunity or something. I'm not sure the solution.
Okay, let's put the call out one more time. Member Short,
Right.
thank you. Ms. Tadka?
Sure thing. So if you would like to provide public comment, you, as we do at all of our meetings, the same process. Call 415-655-0001. Access code is specific to today's meeting, which is 2490777-4857. Then you will press pound, and then you press pound again, and then you lastly will dial *3 to line up to speak.
Is that the only way to comment? Because I got at least one, someone said
Yes, that is the only way to
line
comment.
didn't work
That
when
is
they
the
tried
only way to
calling.
comment, Sarah.
Okay,
The only way to comment.
I'm worried there is a tech issue.
Yeah,
Nope,
likewise. I think I
promise
got a
you
text
that's
someone
the only
that could
way.
not come in.
That's the only way to comment. We've been doing this for 3 years now. This is the only way to comment.
So, sorry, if they're already, it looks like there's a bunch of attendees. They don't have to, they're already dialed in. They should be pressing *3 if they want to raise their hand. Is that correct?
They will need to do this process of
Right.
calling.
I mean,
Yeah.
if we're looking at attendees, could we assume that they've done the whole process? Then all they need to do, because there's a list of attendees, they have to
There's
press
always a list of
*3.
attendees. Sure. I think that, I don't know once they've gotten to this step, whether they just need to dial *3. I think whenever, regardless of whether attendee or they're a panelist, the process for people who are calling in from the public, even if their name is listed here, then they're just listening in order to make an actual public comment, they do have to go through these steps. The last step is dial *3. All right, so one more time, you will call 415-655-0001. You'll enter the access code 2490-777-4857. You'll then press pound and then pound again, and you will dial *3 to live to speak. At that point, you will be placed in a queue with your hand raised, and then we will be able to unmute you.
Any public comment, Ms. Sadka?
No hands are raised.
Okay.
I'm sorry, I'm being told the instructions on the screen are different than what you're describing, Ashley, and I think that might be confusing people. Is that right? Was the screen, what it's saying right there, the same as what you're saying?
Yeah.
It is?
Yes. I just literally read the screen.
Okay. So Fatima, who just called in, said she raised her hand on the computer and that's how she was allowed to speak, through the computer. So why can't we do it that way for these people that are maybe having difficulty with the phone?
That's just how we've been told how to do public comment, but if you would like to raise your hand
When
and you're
that
already
breaks,
in the queue.
I mean, when that process breaks with the phone.
Yeah. Why don't
seems
we
like,
unmute? We have like Brandon Chatham has raised
Great.
his hand. And so
Thank you.
let's unmute that and have Brandon. And for those members of the public, if you could please raise your hand. I'm sorry that we're having a problem with our call-in system, but please do raise your hand and we will call on you.
Brandon, go for it.
Yeah, hi. It looks like you guys are having some technical difficulties. It looks like I tried calling in the number to try it to see if I can raise my hand, and I think raising my hand this way is probably the best way that you guys figured it out. I'm just putting that out there because it's not very user friendly. So, and I think you guys are getting around to it. I just wanted to help you guys out. That's all.
Thanks, Brandon. Go for it. Is that all you have to say?
Yeah, that's all I have to say. Yeah, it's a little bit.
Thanks so much. Thanks so much.
Yeah, it's not very user friendly, but I think you guys are coming up with a really good solution because I've been trying to call and it's not very user friendly.
Yeah, this is the way that they told us to do it for the last several years.
Okay, gotcha.
Thanks so much, Brandon.
Okay, thank you.
Any other public comment?
Okay, well, I guess what we'll say is, Ms. Dyka, let's close this out and we can invite folks to in person next time. Or there'll be a real public comment call in then.
Yes.
Yes.
Well,
not
and
over WebEx.
I do want to note that there is an email. So, apologies to the community for the technology situation. But it is in the agenda. It's listed. It's mental health SF IWG at sfgov.org. So we do monitor that. The controller's office monitors that. We will be looking at that and bringing that in. And as Chair Lassar mentioned, we will be in person at the, at coming meetings. And so technology should not be a barrier anymore.
Awesome. Thanks, Jen. So we are going to close public comment now. Go for it, Chair Lassar.
Thank you. I'm just getting to the right slide. Please go ahead, Ms. James.
Yeah, so we have two items that we want to focus on. So we had a number of things on the agenda. So just to kind of reconfigure where we are, we were going to have new beds and facilities and the Office of Coordinated Care as presentations. Given this morning's conversation, we just wanted to note that these aren't going to be resolved today, but we are, as Chair Lassar said, we are taking down all of the notes. We have the minutes, we have the recording. We're going to be developing all of those questions and pulling them out, and we will find another place to have this discussion. But the discussion will be much larger probably than this group, particularly given fire's participation or emergency management. So We have two things that we'd like to do for today that connect, not the OCC and the new beds and facilities yet. We want to talk about the mapping discussion, which is part of this, been something that's been asked for from the very beginning of IWG. And so there's been some progress on that the group has made that should inform some of these questions that you're having. And then we also want to talk about the retreat group met and came up with a plan for an agenda, and we wanted to talk to you about that. And if we have time left over, then we will talk about probably the OCC if there is time, but we don't want to push that, and we want to make sure that you're all in this kind of the mental space to be able to take it in given where we are. So let's go over to the mapping discussion, and we have Member Salinas is going to be presenting on that discussion. Can you advance? Member Salinas, are you there?
Good morning, everybody. Yeah. Thank you, everyone, for all your valuable input thus far this meeting. Hopefully, the mapping discussion will be a little less contentious. We have been talking about mapping since basically we started meeting as a body, and I think I'm happy to say that it came to light when we met last that with the new Cal AIM requirements, the county, every county has to actually do a mapping of, or basically create a directory of all their services. So the DPH is working on creating a directory of all the behavioral health services in the city, and they are working on upgrading the website to make it more user friendly so that folks can also find all the resources on the website. I think I guess my little 2 cents about it is that hopefully also it will include the pathways to accessing those services, because a lot of our BHS services cannot be accessed directly. So also as providers, like as an ICM provider, we can't just take referrals, self-referrals. So it'd be good if the directory will indicate to which programs one can self-refer and what do you do to do that, and to others that require interdepartmental referral. The other the other component then of the mapping that we will be working on, or that folks at BHS DPH will be working on to help us understand the spectrum, is basically a mapping to help us understand the spectrum of care. So the continuum of care. So they will be creating maps, three distinct maps, starting with that encompass the various clinical / identity, and how, because we understand as clinicians that very much also identities present as a clinical need, right? Being a non-English speaker, for instance, being a woman, for instance, having complicated medical comorbidity, well, that's not an identity. Never mind. Step that back. So these three clinical presentations will include folks that are dually diagnosed, folks that are male, female, someone with children, someone forensics involved, a TAY youth, a non-English speaking undocumented person, and someone with complicated comorbidity. So they will create these three maps, commencing basically from the ED or from when someone might get picked up by EMS 6 and taken to the ED, and a demonstration of how BHS envisions, like the vision, like the ideal, how someone should move through the continuum of care from that point of being unstable on the street to being stable and in permanent supported housing. And so that we can understand what is the vision of how our continuum of care should work. And I think that these will be good tools for community meetings with particularly say with providers, so that we can then take this to our community meetings with providers and understand how this is or isn't working, right? And where there might be gaps in this continuum of care that need to be addressed. And so that hopefully we can make better, this body can make recommendations to BHS for what programs are needed, or, you know, like in our last discussion, how programs should be modified to better address these gaps in care. Is that, as we understood, mental health SF was meant to look at what are the gaps in our current system of care and what needs to be created or restructured in order to address those gaps. So I think hopefully we can then use these as the jumping off points for evaluating what needs to be restructured, what needs to be expanded, so on and so forth, in order to make so that vision can actually be the working continuum of care that we would like to see.
Yeah. And Member Salinas, just to add, you know, like, so the mapping project, you had said this, but I just want to clarify, like in January, we talked about possible community engagement opportunities.
Right.
We are connecting that conversation about how to engage the community to this particular issue, which is like mapping what the ideal system is and what's actually happening. So that community engagement would be connected to this mapping, as Member Salinas mentioned. We also have Ashley here, Ashley Vaughn from DPH, because as Member Salinas mentioned, like we talked about, there's a lot of different ideas of mapping. And so one of the things the mapping group was talked about all the different mapping requests that have come up. So Member Salinas's like presentation of one of the things that we'll be doing is the mapping of the ideal. The other are mapping that have to do with who's in the system, what are the providers, you know, what is the directory, how do we communicate, what is the access? And so that's been called mapping, and it's also part of community access and understanding of services. And so we're inviting Ashley here to talk a little bit about those points that Member Salinas mentioned that are in the also discussed column of the slide. Ashley?
Yeah, hi. I just wanted to take a moment to introduce myself. So I am the communications manager for behavioral health services. I don't think I introduced myself appropriately last time. Andrea, I'm sorry, Member Salinas, did you have something now? Okay. So we are in
That
the
was accidental.
process of developing improved communication materials for behavioral health resources in the city. And that includes redesigning behavioral health services webpage on SF.gov and elevating the visibility of the city's behavioral health services on the homepage as well. And we really empathetically share the IWG's goal to create a user-friendly and accessible page for clients to access information on behavioral health programs and resources, and we're working toward that goal. And additionally, it's a high priority to consistently communicate and simply explain the range of services that we offer across all of our communications channels and for our various audiences, including clients, providers, advocates, and so on. So we are planning for a really robust website to address some of these needs that have been elevated. And we do hear the concerns from the IWG, and we are responding to those as well. With that said, we are also developing specific developing user-friendly resources for that are provider facing. So we are meeting state requirements currently for what provider information needs to be posted publicly in our provider directory, but we don't believe that it is organized in a way that is very user-friendly. And so we are actively expanding resources through hiring, to invest in developing our client-facing web pages in addition to these provider-facing web pages. And just, I want to clarify that we are actively working on how we categorize and describe our programs, including to inform our transition to the EPIC EHR, electronic health record. And we need this kind of review to inform and develop an accurate and user-friendly client-facing resource like a provider directory. And I just wanted to add that, while this may seem straightforward, it's a little bit more complicated than it seems. And so we have hundreds of programs through a variety of contractors, and a lot of these programs provide more than one service at several locations, or more than one program at several locations. And so our list of providers and programs are kind of categorized differently depending on whether they're pulled from Avatar or contracts, and they're pulled in ways that are not helpful for clients. So that's all to say that we're working to centralize access to this information and update each program's function. And we do have the provider directory currently up on our website, and I can also provide a link in the chat to our current webpage, which is what we will be working on.
We have a few questions. Sorry, Ms. James.
Yeah, I just wanted to confirm, do you have some timelines on the things that you mentioned about the improvements to the site, as well as kind of a timeline for, because the mapping project starts with DPH putting together, a lot of work on your part of having to put together what that ideal state is. So just wondering about timelines for all of this.
We haven't confirmed timelines yet, so I can get back to you on that. But these are very, very high priority projects and things that I'll be focused on myself.
Thank you. We have Member Eisen and Member Fields. Member Eisen?
Yeah, I have a question. I'm not sure if it goes towards Member Salinas or to Ashley. Sorry, I don't know your last name. It just says Ashley. I have a question. It's kind of what what I seek from this project is there are, as we even started the meeting with, there are countless, obviously, case management or functions or kind of outreach teams that have case management responsibilities that are divvied out. There's that's not even including the OCC, which I think we'll hear more about. There's street crisis, street wellness. There's the new project it's being funded by DEM, the community response teams. There's intensive case management. There's FSPs, and there's the enhanced case management, which is not even, it's a function of the health plan, right? Of the health plan. And then each provider in the behavioral health realm typically has some responsibility for case management. For the people that we serve. So whether it's people we serve in substance use disorder treatment or in mental health services, there's a case management care coordination function there. And so it's my hope, and maybe this is too large a hope, to get a sense of an inventory of what all those are and how they interface. At least that is less, I think, meaningful potentially, maybe to the client experience, but at least this is where we are today, and how do these things connect to each other? And so when I'm one of the people who keeps asking for mapping, it's that I seek. I seek the how does this interface with who's this person's care coordinator, and what's our responsibility on the substance use side or on an ECM side? So I don't know if that's within the scope of the project, but to be clear, that I think is the desire as a provider representative on this that we really desire.
I think you bring up really good points. I think that we struggle as well on the ICM side of knowing who's. I think because for ICM providers, we tend to do all of it. If this is our client, it all falls on us, and that's may be a thing that, you know, we have just accepted at this point, that, you know, no matter where they are, all the care coordination, you know, all the disposition planning is our responsibility. If there's going to be more care collaboration, you know, if that is BHS's vision, I would hope it comes out in this mapping. I think overall, it's, you know, we you know, it's a good thing to see how is BHS envisioning that we're all supposed to be working together, because I wouldn't say, right, that. And so this is part of the opportunities for when we have these community meetings. If that's BHS's vision, you know, we have these community meetings and figure out how we're gonna, you know, how is that not really what's happening? And then what then do we need to say from BHS needs to be structurally put in place so that it would begin to work that way. I don't know if that answers your question, Vitka.
It does. I mean, I appreciate it because I tend to see you as the expert. And even still, if you think about all of the other entities that have some case management responsibilities, like, how helpful it would be for you to know that? Like, you know what I'm saying? Like, how helpful it would be to say, oh, this person has a case manager in substance use and a case manager from the health plan. And so that's like, in some ways, we're either duplicating care or we're just not doing the best we can for the clients and most efficiently for the system as well. So I think we're in agreement, but I think I wanted to articulate like the vision to the department of when I ask for mapping, this is what I hope to see.
Thank you, Member Eisen. Really great points. Member Fields, please.
I'd like to address for a minute the thing that keeps getting vague in this, which is the intersection between describing what is and describing what should be. We keep confusing the terminology. When I get a map and I'm going to drive from San Francisco to Denver, I want to know what towns are on the road. I'm not going to, there may be a section of the road where I say it would be really nice if there were another place for you to stop and spend the night. Those are two different decisions. A map is a description of what is, and actually what I hear you saying, which is everyone knows is missing. If you're a parent and you have a family member who needs mental health treatment, you want to have some sense of what's available and what are the barriers or the focus of each program. We don't have that, and that chaos creates a lot of problems. That's essential. But I don't want to mix that up with designing the system that should be. I mean, those are two different things. I mean, I would call the second activity a blueprint for building a system, not a map of what we've got. And they're both needed. And, you know, there have been statewide efforts. There, you know, the California Hospital Association with NAMI California, the Families Group, and over just the last 2 years has laid out their idea of what should be present as a service availability based on best practices or counties that have them in every county. That to me is a blueprint, as they call theirs, for change. I think there's a lot that has to go into that. I don't think the ecology is addressed enough, which is how many inpatient beds do you really need in a county? Well, if you have no crisis residential beds, you need a lot more than if you have that service available. That what you need of one level of care is affected by what you provide at another level of care. If all you offer between inpatient treatment or emergency room is for housing is a hotel room, there's a lot of things on that road should be there, but if that's all you know about. So like in 1978, if we were doing this mapping project in San Francisco, no one would have mentioned acute diversion because no one had done that yet. So the mapping would look one way. In 2000 or in 1995, when there were no alternatives to IMDs and skilled nursing, you'd say, well, here's what we have. Here's how you should, if you need this, you go to skilled nursing, and here's how you get there. It takes vision to say, we don't need to treat everybody in institutions. We want to treat people in the community. So that's the decision we need to also make is what's the goal of our system of care? And then what do we need to get there? That's not mapping. That's a vision, a blueprint for how we transform our system to be responsive. And then when we open these things, they become a part of the map. And I don't trust any one sector, DPH alone, the community alone, providers alone, to describe what that system of care should look like. Nobody's the expert on that. But that's what we should be discussing, is what are the gaps in our system that we know could be developed if we had the will and the ability to do it, that prevent or that accomplish and lead us toward our goal, which I believe is recovery, stability, and thriving in the community, not how many IMD beds can we buy and how many hospital beds we can do for emergency interventions. They're two different things. Thank you.
Member Fields, just could I just ask something clarifying? So the mapping project we're talking about is a client level path of what an optimal, like moving through the system and what that optimal state would be and where the breaks are. And that's one kind of mapping. You're talking about a kind of a higher level of mapping of the entire system. Is that right? So you're not saying no to this mapping.
Right. No, but Jen, let me just clarify.
Yeah,
so,
please do.
I really appreciated your terminology today, Member Fields. And so the mapping that we've been talking about is navigation. It's navigating the system. And like, how do I get from here to Long Beach when somehow I ended up, I'm in, I'm in the middle of Mendocino, and like there's no straight road there. And then what are all my barriers and how do I get back there and what do I need and where do I stop and like all those things, right? The not higher level, let me not say higher level, let me say the most pressing thing that we have in front of us is, and I think it is our desire to actually design, right? That's what we were asked to do, design and then implement and give feedback on, right? The landscape of what it should be, visioning. So this is the visioning, the vision board. Yeah. And we're not at the vision board. We're in many cases nowhere even close to the vision board. One thing I have to add to the vision board is also prevention and early intervention and all of the things that are parts of social determinants of health that then later and all of the prevention also must get embedded in anti-racism, anti-homophobia, anti-transphobia, gender, all the things in that are that plague our community, anti-immigration. Those are also parts of this vision board. And so it kind of goes to, the I Have a Dream speech that Dr. King really speaks about or spoke about. We may not get there in our lifetime, but we cannot let it go that we can get there. And so that's the landscape that we want to create, and that's what Steve is talking about, and that's the biggest, highest aspirations. And then also now we're tasked with what is here, how do we navigate with these barriers and boundaries and problems and isms and lack of resources in the best way that we can and know how, and how do we hack what we currently have, frankly. So I'm going to pause there because I see Heather Weisbrod and Dr. Cummins have their hands raised.
Yeah, let me, why doesn't Heather go first?
Good morning or good midday, everyone. Nice to see you. I just wanted to very briefly offer that I think some of this discussion about the vision and how people get into services and navigate our system are the very questions that we've been grappling with and really thinking about deeply in the planning of the Office of Coordinated Care. And so I'm hoping that as we continue discussing that Office of Coordinated Care, we can shape that vision, continue shaping that vision together, and that what we're thinking about will become clearer. I know that we were hoping with the case management expansion discussion we were going to have today to start to illustrate some of that flow, and how the different programs, OCC and different programs in the treatment system work together. I understand that may need to be held off, but I did want to just offer that I really appreciate this discussion because it's very much something that we're thinking about in terms of entry points into our system, existing and ones that we need to build, how we support people, where the gaps are, where the barriers are, and what we need to do to address those. So, thank you.
Dr. Coonan?
Yeah, and I came in as Member Salinas was just commenting specifically, just this is a little bit for Heather as well, on the case management function within ICM and how that relates to other case management that might be happening in other sectors or with other providers, as sort of just to tag that. Just a comment on mapping. I think a little bit in the spirit of this morning, the earlier part of the conversation, I just want to kind of convey to the group that we have been really struggling, I think is a fair word, to meet the requests of the IWG in the mapping requests. And it does feel like it's kind of an ever moving target. And so we are really wanting to be responsive and deliver the sort of multiple things that all of you have raised and which we agree are high priority. So I think I would just kind of ask, and I know Ashley's on, and I came in a little bit late, to try, even if it's not answering all questions forever, to kind of try to move through so we can get something that's delivered to IWG that meets at least some of the needs. So we can, and then we are delighted to then like kind of move on to the next request. And I think what we've all heard over and over again, mapping means many different things. And thanks, Carla Sarr, I heard you say, this is what I think we're working on. So we are eager to meet your requests here and are having some difficulty because we're hearing different things at different times, and need help really staying, I guess, concrete and then sequential, I guess, is my request for help from you all.
Thank you so much. I think the concrete piece is where I think we are, and I'm coming to you, Vice Chair Patterson. The very concrete thing is exactly what maybe Vice Chair Patterson is going to speak about, which is I always have the vision of your mom and the wall of how do we get community to service. So Vice Chair Patterson, please.
Well, that was kind of what I said earlier too. In addressing Dr. Coonan, I know she was mainly talking about hiring, African Americans to address the disparity in health. But again, it's like, what is like the plan going to be? And I want to see us like really just, okay, let's look at the city. Where are most of the programs located? Tenderloin. What programs do Bayview have? What programs does the Mission have? What programs does the Fillmore have? And just, let's navigate, let's start doing that. How many mental health clinics do we have throughout the entire city? What services do they need? Which one is the best? The one, the Bayview mental health, I had a lot of great experiences at that one. I used to go to South the Market mental health clinic. The one more so downtown, I think kind of close to the financial district, wasn't as well. Then you also got West Side Clinic. You have Rafiki, which is not technically mental health, but it's in the lane. You know, a lot of what we covered as far as just being a part of this has mainly been in the homeless field. And I feel like a lot of this because of like politics, like, you know, Donald Trump called us a shithole. And downtown and the Tenderloin and everything on the news. So everything we cover is like, most of the stuff we covered has been around the homeless issues. And I do understand that mental health bleeds off into that. But let's still kind of map and navigate what the city has, what the city doesn't have. And we can do that by the neighborhoods. It's not even like, you know, trying to count everything in the city. I'm just, you know, I know the Mission, Tenderloin, Bayview, maybe Fillmore. Those are like the four, as far as what I see in my experience, my lived experience and professional experience. Those are the four areas in the city that has mental health. And let's do that first, but then I also think like Kaiser has something around that. But, you know, that's a whole other lane. I haven't, you know, explored that. So I'm just wondering, like, why we can't get to that ever. What's in the Mission? Where is it in the Mission? What's in the, I mean, we've talked to some people in the Tenderloin here and there, but what's in the Tenderloin? How much? Where? What's in the Bayview? How much? Where? Like, how many institutions and buildings and facilities that's dealing with mental health and mental health issues? I'll land a plane there.
Thanks for the landing. And it's right. That's what exactly we're speaking to. The concrete pieces, Dr. Cunnins first. So that's where we start.
And we are, Vice Chair Patterson and everybody, I concur, and this should not be as slow as it is, and we are working on that piece and very sharply, and I agree and hear the urgency of that, and we are on that, and that is extremely helpful. Thank you.
Thank you, Dr. Cunnins. And I think that the thing that really came to light, yes, we can move on to the retreat in just 1 second. I'm going to take prerogative and say the last word here. I'm getting a note. Is that the communications piece, the community engagement, community reaching out, and the community being reached back to, is really important. And so I'm hoping that we can get into that. And that is also this whole communication piece that Ms. Vaughn has, that we spoke about also with Director Rocha. So I'm very excited about that, and I'm looking forward to some communication working groups. So I just want to name that for anybody that is listening in terms of community, that if you want to have your voice heard, please do reach out and email us. I think it's mental health SF or MHSF at whatever it is. You can say what it is, Ms. Dyke or Ms. James. But let us know if you want to participate in these communication conversations out with community, because it's really important that we get community input. Thank you so much. And I will.
And Chair Lassar?
Yes.
It's Mental Health SF IWG at sfgov.org. That's also on the website, and it's on the agenda. Sure thing.
Thank you. So do we go to public comment now? Is that what we do?
Yes.
Thank you.
Well, and remember the raised hands, folks. We're having some problem with our technology.
Thank you. Ms. Sadka?
Oops. So those who are calling in, they aren't currently attendees who are in the meeting, will call 415-655-0001, and then you'll enter the access code 2490-777-4857. Then you'll press pound and then pound again, and then you can dial *3 to allow to speak. If you are already an attendee in our meeting today, you can then also just raise your hand and we will then unmute you. I see that we have one caller, so I'm going to request unmuting you and then you may begin your comment. Go for it, Ruben. We can't hear you, Ruben, if you are talking.
Ruben, we can't hear you.
You are unmuted, so you should be able to voice. Maybe you, I will lower your hand, and if you want to raise your hand again.
Ruben, you might check your own, we have you unmuted on the system, but you might check your own system and see if there's an unmute.
Hello, can people hear me?
Yeah.
Oh, hi, my name is Ruben Kessler. I'm sorry, I was having some technical difficulties. I'm a program coordinator at SSVF, Swords to Plowshares in San Francisco. I was just wondering, I've been coming to a few of these meetings over the past couple months and taking notes. But I was wondering what the city is doing to, I guess, to incentivize new mental health professionals to come on board, to get new social workers, caseworkers, and keep people because, our organization, we have had a lot of turnover. It's constant. And I'm just wondering, on a surface level, what is the city doing and, community organizations are doing to, you know, solve that problem of turnover because we're talking about services um, and all these plans. But if the staff is turning over every 2, 3, 4, 5, 6 months, and then the trust is broken, with the clients, what type of plan do we have in place for that?
Yeah, thanks so much, Ruben. Chair sorry, I know can't make any direct comments, but if you want to say anything.
We are with you, and please send an email. I think we can respond a little bit more directly in that setting. And we are absolutely fighting for all of the same things. So thank you, Ruben.
Yeah, thanks so much, Ruben.
Appreciate it.
Appreciate you. Any other callers in the queue? Currently don't see any other callers. I'm just going to remind folks of the process. If you are already an attendee, you can just raise your hand and are already in this meeting. Otherwise, call 415-655-0001 and that access code for today, 2490-777-4857. Since there are no other callers, I think I'm going to close public comment. Are we skipping this break? Or are we? Cool.
Yes, we're skipping the break.
All right, back over to you, Chair Osai.
Thank you. March retreat. So this, we're now moving into March retreat discussion group, discussion item number 6, report out. A discussion group met to talk about how to organize ourselves for our March retreat. The group included Amy Wong, James McGuigan, Steve Lipton, Steve Fields, and myself. Next slide. And do you want to take this one, Ms. James?
Nope, Member Lipton's doing it.
Oh, great. Perfect. Thank you, Member Lipton.
I drew the short straw. So to tee up this discussion, as the chair mentioned, there were 5 or 6 of us who met just yesterday. After yesterday, we only met for about 45 minutes. Jen kind of teed up the conversation with a couple of thoughts about, what do we need to walk out of the retreat in terms of what our goal is? What are they, how do we build discussion around the design of mental health SF? Where do the IWG December implementation report fit in versus the department's implementation report? And what do we need from DPH to have a successful retreat conversation? After some discussion, we threw out a couple of ideas, and this is just a preliminary list. And clearly, after today's meeting, there may be other ideas as to what perhaps we should be focused on. But the 3 things that came out from the committee was we should probably devote some time, and I think we could try to limit how much time this is, just to get to know each other a little bit better. It'll be the first time we'll be meeting in person. And so we should spend maybe first half hour or so on that discussion. Secondly, there was some discussion among the group about a sort of a big picture issue about how the IWG can facilitate the evolution of mental health SF to a system of care that's envisioned under the ordinance. I think Member Fields may want to address this, that this was his primary comment, but that's sort of an overarching piece. And the third one, which I think dovetails with what we discussed this morning on the SCIRT teams, and is exploring prevention and early intervention opportunities to serve the MHSF population before we actually deploy crisis or intensive care services. So those are the 3 initial goals, but I think the opportunity is wide open for having further discussion and try to tailor this down. If I understand correctly, there'll be another conference call among the retreat planners in the next week or so to try to nail this down a little bit further, but this is a good opportunity for input. So at this point, I guess I'll turn it back to the chair and just say that the door is open for suggestions and any help that people would like to give.
Thank you. Great short straw. Member Lipton. Any hands? I'm not seeing any yet. Would anybody like to weigh in? I know it's been a long day and it's been a lot going on. So if you're not able to articulate your thoughts right now, send us an email. Please, Member Hammer.
I'm not sure if this fits under initial goals, but just to reiterate what I said earlier, at the risk of being repetitive, is I think that that the retreat will be a good place for us to explore this question that we've been struggling with, I think, since we convened, which is how we interact with the departments so that we can given the constraints of timing and how fast things move in the city, fast and very slow, so that we can give really meaningful input to programmatic development and really meet the vision of the IWG when it was included in the legislation.
Thank you. Member Eisen?
Similarly, to really think about how we can interact with departments in real time. Like, these are things we're thinking about. These are things that may or may not be working. What are your thoughts? So that it really is dynamic and not kind of, there's a whole report and we sit and react to that. I'd love a brainstorm how to have a really dynamic relationship with implementing the legislation.
Thank you. Well said. Member Salinas?
I guess just picking, so off of what Member Eisen and Member Hammer said, I mean, are in section number 2, can you explain what is that section meant to address specifically, like the details? Are the issues that Member Eisen and Member Hammer meant to fall under section 2, or is this more about exploring what services are needed to create a more, I don't know, to improve the system of care? What?
I mean, I'm happy if you're asking for clarification.
Yep.
In my mind, it's a combination of both, right? So there's a lot of portions of mental health SF that have been implemented and have been for a while. And so how do we take a look at that? What's the process by which we look at how that's going? Or if in fact some problem has arisen in the project, and so we brainstorm solutions. So that is how we look at work that started, and then how we envision the work going forward. Because this is all dynamic, right? You try things, they could be made better. How could they be made better? There's problems you didn't expect, and then how do we build a system that really delivers on the vision of the legislation? So it's both of them. If that's helpful, I don't know if that's helpful, Member Salinas.
And
I think our role is both, right?
And maybe, I don't know, Chair Lassar, if we want to let Member Fields jump in.
Yes, please.
Yeah.
Just as a member of the committee, yeah, I think actually Vitka said it very, very well. It's something I've expressed here before. The legislation calls for a more responsive behavioral health system for all San Franciscans, all of them. It's not just the people who are in crisis, which we obviously need to address first. So the idea is if we spend all our time on standing up programs that are dealing with the failures of our system, we've got to look at what creates a situation of recidivism and constant utilization of emergency services. That is not an inevitable result of a system of care. So this is an attempt to say, as we go forward, let's work in partnership with the departments, and particularly DPH, to envision what those elements are that will not keep us in a constant response to crisis systems. It's not the inevitable result of behavioral health. We can envision a system of care that can prevent that constant recidivism. So yes, we have to respond to the current crisis that's on our streets because we've been part of creating that crisis. We owe it to those individuals to help them, but we owe it to them to look at what is it about our system of care that doesn't help people get towards independent self-determination in the community. And that's this part. That's part 2 of participating in MHSF, because it's not just a vision for when we failed, it's a vision for what did we not do that we could have done to prevent people being in that situation.
Indeed. Member Vice Chair Patterson?
Yes. You have to avoid number crunching. Number crunching is the enemy of impact. Because you can just show some numbers, and the numbers say we're fixing the problem, but the community isn't feeling the impact or not seeing the impact, we just move on and try to never crack some more. And I think what we can do is even develop a ladder system. It's not perfect, but how can somebody get from being their worst mentally, get from being homeless, because we're talking about a lot of homeless issues, to working and contributing to society? What are the steps that they can take? And I think we have so much in this city. You know, Hospitality House has been around since the 60s. So we have so much in the city that we should be able to develop a basic ladder. And no, numbers don't lie, but they don't tell the whole truth. That's why number crunching is the enemy to impact. Because you have communities all the time, Black, LGBTQ, brown communities, to where, they say, hear the numbers say that the communities are doing better, and the community doesn't feel the impact. I land the plane.
I think you mic dropped. Yes, thank you. All right, so I think we have input from everyone. Are we able to move forward to the next piece on this?
Yes,
So
I
public
believe
comment,
so.
please. Yes, thank you. Ms. Godka, if you could take us out one more time.
So if you are joining us in this call today, you can just raise your hand. Otherwise, if you'd like to go through the process of calling 415-655-0001, access code 2490-777-4857, and you press pound and then pound again, and then you'll dial *3. Otherwise, you can raise your hand. I'm going to see if there are any callers in the queue. I see Kat. I'm going to request unmuting you, and then you may begin your comment. Go for it.
Me?
I hear you.
Okay. My name's Kat Koppenrath. My pronouns are she, her. I was a licensed crisis response clinician on SCIRT from June of last year until last week. I was unable to make the initial part of the meeting and jumped in right around the public comment section for item number 6. I was hoping to make my comment now, if that's okay.
Yes, please.
Yeah, go for it.
Okay. As I imagine was previously discussed earlier this month, my colleagues and I were called into a last-minute meeting where we were informed that in less than a month, we as mental health professionals would be removed from the crisis response model and replaced with EMTs, ultimately losing our jobs that we signed up for. A huge role of these clinicians on these teams included facilitating or finding alternatives to 5150 holds, utilizing creative interventions, and taking time to work with folks in the continuum of crisis. As I'm sure many of you know, this work is not easy, especially in an ableist system of care embedded with all of the isms that Monique alluded to earlier, one that fails to provide innovative spaces for care that aim to really help people be well. For example, one kind of like image and experience that always sticks with me is when a client who is struggling works to engage in a safety plan by taking space to rest at door urgent care and are initially screened through a cage door, which feels dangerously parallel to our oppressive systems of incarceration. I just want to also name that the impact of this decision is, obviously multi-layered, nuanced, and threatens more violence towards our community members. When we focus on data, and as this SF Chronicle kind of alludes to lately, clinicians not being able to write enough holds, we sit in a dangerous place contrary to our ethical obligations. This threatens a continuation of blending the mask of public health harm reduction and carceral coercive care. As the city continues to push for removal, displacement, and institutionalization of unhoused people, I am concerned and my colleagues are concerned. I want to name the complicity of carceral social work and behavioral health systems here, and I acknowledge that these things won't inherently end police violence or institutional violence. That work always begins with ourselves. I also want to name the devastation for those like myself who have worked daily to reduce or mitigate institutional harm in these spaces, especially related to 5150 holds. This feels like a setback. We're losing qualified, passionate clinicians to other systems of care in other counties. And I'll just kind of end my statement with a quote from a book, Viral Justice by Ruha Benjamin, that I've been leaning into. If you don't actually change the culture of a system, you just replace who's doing it. It isn't possible to change a social structure without changing its culture, and we can't change culture without changing ourselves. Thank you.
Thanks so much, Kat. Really appreciate you. And yeah, anything, Trellisar?
Oh, thank you, Kat. I'm so grateful that you're here.
I'm going to see if there are any other callers. Currently, no other callers in the queue. We're going to wait a few more seconds. Again, folks who are in the attendee, joining us as attendees can raise their hands. Otherwise, you have the call-in number. All right, I'm going to close public comment.
Thank you, Ms. Vodka. I think we're jumping down to what slide number?
Yeah.
Number 64, is that right? Or no, 63, I guess. Not that one.
Yeah, it's the final comment.
Yeah, the final public comment. So as we're waiting to get there, we will just note that we're going to take the public comment for any other matter within the jurisdiction. So please, Ms. Vodka.
So we are taking public comment on any other matter within the jurisdiction of the committee, but that's not on the agenda today. So you can either raise your hand if you're joining us in the meeting currently, or that number 415-655-0001 with the access code for today, 2490-777-4857. Then you press pound and then pound again and dial *3. I'm going to see if we have any callers. Currently, no callers in the queue. So I'm going to close public comment.
And we're going to skip the next slide, Ash, and just go to the calendar.
Oh no, we can't flip that one.
There was a request to skip it for now.
Okay.
Yeah,
Okay.
so planning and sequencing. We are going to be working with this calendar a little bit at the retreat. I imagine it'll change some, but for now, this is kind of how we're planning. We're having no formal IWG meeting in March. That will be the time for the retreat, but we will reconvene back in April. And again, like this calendar will be something that'll be up for discussion and for thinking about how we organize ourselves and how we organize ourselves with other entities. Next slide. Mm-hmm. Yeah.
And also in March, we'll be in person.
Yes, that is right. Yes, the next meeting will be at the City Hall room 305. And then on April 25th, the usual meetings will resume, and they will now be in person at the DPH building, and it'll be room 515. And we're still getting, I believe we're still getting some instructions about entry at both City Hall and at DPH. All of those meetings should be in your calendars, and we'll be updating those shortly. As usual, like everything will be posted to the website in a couple of weeks. And that email that we've been referencing throughout the meeting, the Mental Health SF IWG at sfgov.org, is a place for public input in between meetings. Chair Lassar?
Okay. Are we just at, where are we now?
I think we're at adjournment.
We're not doing the others, you're saying? Okay. Well, I will just say, for whatever is happening next, I will say thank you to everyone who has participated, and those who have, even on the IWG, who have not spoken, but I've seen you actively listening and participating. So I want to say thank you to everyone. This was a big, heavy lift today. It felt that way anyway. And so I know that we're going to have a lot to talk about when we see each other in person. I want to say thank you again to the team, to the controller's office, to our amazing friends at Harder and Company, to all of our friends at Behavioral Health, BHS, and also our new friends at, what's the acronym? Is it DEM?
DEM, D-E-M.
DEM. At DEM, I don't know what that stands for. I just am tempted to say endem, but I don't know. And so we'll say thanks to everyone. And you all have a beautiful rest of the month. And I guess this is the last day of Black History Month. So I'll say, again, noting that, and also tomorrow will be the first day of Women's History Month. So just thank you all.
Happy Black History Month.
Yeah.
Happy Black
Do we have
History.
I know. Do we
know.
have an adjourn? Do we have a motion
We
to
have
adjourn?
an adjourn. I have a motion to adjourn. Sorry.
Happy Black History Month.
Happy Black History Month.
Yes. We need a motion to adjourn, please.
So moved.
Okay, I made it, and we got
Oh,
a
you
second.
made it, and then Vitka, member
Yes.
Eisen, seconded. Thank you. All right. Bye.